the most comprehensive agreement ever reached on global health. A vision for universal health coverage by 2030.
So from me, if we need any help, we can go to the nearby village. Even the nearby village, it was not a primary case, just private hospital. So I supposed to sleep there, but because of the issue of mosquito and all those things, I cannot be able to sleep there. It's not supposed to be like that. The last time I needed health care is when my friend was not feeling fine. Because it's a health center, it's a place where I was expecting that the money is not supposed to be high. Then remember, when you don't have much money, as well, go and rescue your child. But the bill was too much. It needs urgent care.
They say that they don't have something to test the whole thing and then the drugs. There's nothing there. The one that shocked me recently is the one that they also about children. So very close to my house here, to the center, very close here. All the time that there is no medicine, there is no testing. Center here. This guy is involved in
Good morning, all. You are welcome to Yardra Center, the venue of 2021 Universal Health Coverage Summit, the first of its kind being organized by a locally led initiative, Universal Health Coverage 2023 Pro. My name is Mustafa Alawudi, and I'm co-anchoring with me is
Good to be here. Okay. Apologies, we're starting a bit late, but we welcome all the distinguished guests here today. Let's kick off, please, with the first stanza, please, of the national anthem. So if everyone could please rise, and we'll take the first stanza.
Thank you very much. Let's have our seats, please. We'll soon establish the proper protocol. But before we establish the protocol, let me remind us that we are here to change the health narrative in Nigeria. There's no gainsaying that we have not achieved the desired level of quality access to healthcare in Nigeria. Perhaps we don't need a reminder that there is gross underinvestment in the health sector in Nigeria. However, like I said earlier on, we're here to change the narrative. And to turn things around, we have to do things differently and do different things. In order to do things differently and do different things, we have traced the footsteps of countries that have made progress on the journey of universal health coverage. And the important thing that we discover that they started their universal health coverage journey as a political process, followed by, that's where we are gathered here to have that conversation. And hence the theme of this summit, which is about putting health and health security on the political front burner. Why are we doing this? The essence of doing this is to ensure that we use the power of ideas to influence the ideas of power. How do I mean? By power of ideas, those of us in the room know what works and what doesn't. But until that aligns with the idea of the powerful policymaker, we are going nowhere. So in order to make the progress, that's why we are coming here to have the conversation on how to make progress. I'll hand over to my colleague who will properly establish the protocol. Vivian. Buki, let's have the list of the protocol quickly, please.
While Buki is bringing the list, I'd also like to acknowledge many of our participants who are joining us online. You're welcome this morning, as well as some of our distinguished speakers who will be joining us online and we'll be introducing. But before we go further, I'd like to welcome some of our very distinguished visitors here with us today, starting off, of course, with the former Senate President of the 8th Assembly. You're welcome, Senator Bukola Saraki. Thank you for joining us this morning. The Honorable Commissioner for Health, Osun State, aptly represented by the Executive Governor, aptly represented by Honorable Commissioner for Health, Osun State. Apologies for that. We have also with us the Executive Governor of Kaduna State, aptly represented by Honorable Commissioner for Health, Dr. Baloni. You're welcome with us this morning. With us present, of course, is Chief Makanjola. Welcome. Good to have you today. Representing the country director of the World Bank in Nigeria, we have the program lead of the World Bank, Tikabe Belay. You're welcome. We also have with us the executive governor of Nasarawa, aptly represented by His Excellency, Dr. Emmanuel Akabe, the Deputy Governor, Nasarawa State. Representing the founder, Wellbeing, Her Excellency Toyin Ojoro Saraki, we have Dr. Otun Adewale, the National Program Lead, Wellbeing Africa. From Kogi State, Senator Ahmed Abenga. You're welcome. From Nasarawa State, Senator Shule Adekowe, you're welcome. Then the Director, Senior Technical Advisor, Dr. David, representing Honorable Minister of State for Health, Senator Mora. And then representing the Executive Governor, Dr. Kayode Fayemi, we have Dr. Oyebanji Filani, the Honorable Commissioner for Health, Ekiti State. You are all welcome today. And as I mentioned, we also have some of our distinguished speakers who will be joining us online, and we'll be introducing them this morning. As Dr. Gafar mentioned, this is a very important day.
And I know the year is ending, but holding this conference this morning is extremely important as we lead until the roadmap to 2023 with the general elections. And so we're very pleased today to have such a distinguished lineup of speakers, which speaks to the desire for Nigeria to chart a new course in achieving universal health coverage. Dr. Gafar will lead us through the roadmap of how the sessions will be outlined today, and then we can then start our program and introduce some of the speakers who will be making some opening remarks. Thank you.
Thank you very much, Vivian. As Vivian was establishing the protocol, we have Professor Nasir Zambo, the Executive Secretary of National Health Insurance, to join us. Welcome, Prof. So I'll quickly take us through the structure of this summit. Vivian has told us why we're here, and we have established the protocol. So I'll quickly be looking at a key presentation will be delivered by our major collaborator for this summit, which is the Chatham House at UK. They will set up the stage. They will set the stage by telling us what is happening elsewhere, what can we learn elsewhere in terms of putting universal health coverage on the political front burner. Then we'll be looking at what is the situation in Nigeria in terms of what are the gaps, but more importantly, what are the key promising policy trusts that we want the political stakeholders to be more familiar with. And then, of course, we are going to take a welcome address by the chairman of this forum, a veteran media guru, but public health specialist as well, Dr. Moji Makajola. And then His Excellency, distinguished His Excellency, the President of the 8th Assembly, will share his experience and his thoughts about how to move health forward in Nigeria. Then we're going to the panel section where we'll be looking at the issue of putting health on the political front burner. Then we have a second section where we'll be looking at what are the tools, what are the policy tools that are already available in Nigeria, what are the challenges with them. Professor Sambu will be leading a presentation on that, then we're going to have a panel section. And the last section for the day to close is section around obtaining commitment from the various stakeholders. So before I invite Auntie Moji for our presentation, just a couple of more recognition. I would like to recognize the Executive Secretary of our National State Health Insurance Agency, Dr. Gaza Gomila, and then the DG of the Nigerian Governors Forum, ably represented by Dr. Hamad Abdul Wahab. You are welcome. Thank you very much. So, permit me to also recognize Dr. Abubakar Yunusa Hamad is a member representing Yamatu Deva Federal Constituency, Gombe State. You are all welcome. So on this note, I would like to invite the chief convener of this forum, the woman that has done a very great job trying to use our power, skills, and knowledge and social capital to mobilize various stakeholders together. Somebody that is very, very passionate about the issues of advancing health. And so for some of us that comes from the same state with her, we started watching her on television like 35 years ago and 40, and our aspiration was to be a media person. But unfortunately, that never came true. So the pleasure is mine to invite Dr. Mrs. Chief Mojimo Kajola to welcome us to this very important forum. Popularly known as Auntie Moji, even a year-old guy called her Auntie Moji. Yeah.
Thank you very much for your very generous introduction of me. Oftentimes in my more than 35 years of working, I've always been on this side, trying to introduce people and getting it right. And so today, just going to welcome all of us. But before that, let me just apologize profoundly that we're starting about 1 hour, 30 minutes behind schedule. So unlike me. But the culture that we have in Abuja, that, oh, if it's 9 o'clock, don't go at 9. At 10, they'll be ready. We have been ready from yesterday. It's just that we wanted people, and we're not disturbed by the number of people that we have here. We're actually galvanized to know that today is just a beginning of several things that we need to do together. Having said this, Your Excellencies, all very, very, very distinguished members here, my friends, my colleagues that are here, today is a particularly fulfilling day for me as a person and as a professional. And I've just been christened Dr. Moji. Well, we'll talk about that later. But most importantly, it is with great joy and excitement that I stand before this high-profile gathering of political heavyweights, the civil society actors, development partners, and my immediate constituency, the media, to give these opening remarks. For the past 4 decades, I have been part of various efforts aimed at repositioning the health system to make quality health services available and affordable to all citizens, especially the poor and the vulnerable population amongst us. And today I stand in memory of my mother, who died as a result of inadequate health facilities, as at the time she took ill in an accident, bled to death, as it were. So it is on behalf of all those living and dead that I stand before you. While those efforts have led to considerable progress, a huge gap still exists, and Nigeria's health ranking is not a reflection of the country's abundant potential, human and material. Nigeria, like many other low and medium income countries, have adopted universal health coverage as its main policy objective, as articulated in the 2016 National Health Policy document. However, the country is not on the trajectory of UHC, given its unacceptably also exposed low coverage of the perfect 5% basic healthcare services. The ongoing COVID-19 pandemic has also exposed the country's suboptimal health security system. The slow progress of UHC and gaps in the health security system are attributable to suboptimal public financing for health gaps in the country and weak accountability arrangements for public financial management at all tiers of government. Suboptimal public investment in health is a manifestation of a low level of attention and priority given to the health sector by the political class of the country. This is in spite of being signatory to Abuja +12 declaration recommendation of minimum 15% of budget for healthcare. While countries that have made significant progress in the direction of UHC have pursued courses of action that suit their context, there are notable commonalities among them. First and foremost, commencement of UHC journey is usually preceded by a political decision to set a country on the trajectory of UHC, often catalyzed by growing local clamor to care and minimize financial hardship. A course of action needed to address public issues. Examples abound of countries that took advantage of the special political atmosphere in the peri-election periods to heighten clamor for policy reset in favor of universal health coverage. Countries as diverse as Ghana, very close to us, India, Malaysia, Turkey, and others commenced their UHC journey by putting health reforms on the political agenda. As the 2023 general elections approach in Nigeria, they also come with abundant opportunities which could be leveraged to engage the political class, acquaint them with gaps and challenges in the health sector, deepen their knowledge about existing policy thrusts, and guide them to articulate a context-appropriate course of action that is capable of setting the country on UHC trajectory. Considering the foregoing, it is pertinent to form a robust coalition that will bring the wide array but relevant stakeholders together to form a formidable force that will put them on the political front burner ahead of 2023 general elections across political groups. Just by diversion here, I'd like to say that invitation was extended to all the political parties in this country concerning today's summit. So it's not one-sided because diseases don't have barriers. The UAC 2023 Forum, a platform convened by the International Society for Media in Public Health, which I am the founder and also the Chief Executive Officer, the Development Governance International Foundation, DGIF, and other well-meaning sector stakeholders, is a platform established for mobilizing health policy advocates, the media and political class towards charting a narrative-changing course of action that will accord health appropriate political attention and set Nigeria on the course of UHC. The self-made coalition, ab initio, has neither funding, and I'd like to stress this, has neither funding nor support, save for what it could garner from its members. It's cramped from miscellaneous sources of its members to manifest the power of the voice and the determination to make a change to our weak health status. This is a Nigerian initiative by Nigerians for Nigerians. Hitherto, policy advocates and the civil society at large have not quite successfully taken advantage of opportunities presented by elections to create a policy window for advancing discussions, engendering health policy thrusts, and seeking specific policy commitments from the political class. A lot of times we are promised we will provide health during campaigns, but maybe people do not know how broad health is. And so they make pronouncements on giving health for all. And oftentimes we don't get this done. Promises are not fulfilled. This is partly due to their inability to create strong coalition to pursue a clear health agenda for an adequate length of time before general elections. The UHC 2023 Forum seeks to do different things and do things differently by forming a robust alliance that articulates a clear health policy agenda to be adopted by the political parties. We hope that as we go on with the movement, we'll be able to engage political parties across board. The forum seeks to form a robust coalition long before the electioneering process reaches the climax. The UHC 2023 Forum is setting a clear agenda around UHC and forging a consensus for its adoption across political lines. Despite the challenges and seemingly slow progress on the path of UHC in the country, there are islands of success that bring a ray of hope and assurances that we can get it right. The summit would not have been possible without the support of our collaborators, including the Chatham House UK and the Nigeria Governors Forum Secretariat. I particularly thank all members of the UHC Forum represented by logos on the banner. Let me remind you, however, that the journey is a marathon and not a sprint, after which, health-wise, no one, I pray, would be left behind. Health will be available for all, irrespective of their status, class, and social standing. I would like to close first by thanking all of you for making time to be here. Particularly, I'd like to thank my special, I call him my special SP, Senate President of the 8th Assembly, maybe because we are quarants, or maybe because he's a doctor. But he's always available for whatever I'm doing. Thank you for showing up, and thank you for coming. I know that you're being dragged back and forth, but I need to put this on record. I thank you and I salute you. Welcome. I'd also like to appreciate all the honorable commissioners that are here representing your executive governors. It shows that together we'll do it better and faster, and I'm sure we'll get there. I'd like to recognize in particular the deputy governor of Nasarawa State. I know that if you listen to his doctor today, he probably won't be here, but thank God he's a doctor himself, and there are doctors in the house, but I know nothing will go wrong with you. Thank you very much, Your Excellency, coming all the way from Lafayette to be part of this. I'd also like to recognize my colleagues. I'd like to recognize all of you here. I'd like to recognize those who represent my mother today, Professor and Mrs. Obaro from London. Thank you very much for being there with me all the time. And thank you all, development partners. Again, I'd like to stress, this is inbuilt by Nigerians for Nigerians. We are not working on any grant. We have not accepted money from anybody except those on the forum who voluntarily on their own brought in money to put this all together. And to all of you, I say thank you. I would like again to stress that the moment that I will be fulfilled as a health policy advocate is the day that other countries start coming to Nigeria to learn best practices from our health sector. That indeed is the true reflection of our potential. It has happened before. I want it to happen in my lifetime again. Thank you for listening today and thereafter supporting UHC for all Nigerians. It must be done by us as agents of the much needed transformation of our health sector. Thank you for listening.
Thank you very much. Thank you very much, Auntie Moji, for that very impassioned opening message. I think one thing you said, or many of the things you said, really resonated, especially the fact that the road to UHC is in our hands as Nigerians. We have to do this ourselves because this is our destiny. And we have a duty to all Nigerians to ensure that equitable access to healthcare becomes the norm. And everybody in Nigeria has the right to good quality healthcare. I'd like to acknowledge, before I go on to introduce our speakers for the good old messages, a few other distinguished guests who have joined us this morning. I saw briefly Dr. Ben Nkechika, who has, I think, stepped out, and he is representing the governor of Delta State. He's the executive secretary of Delta State Contributory Health Scheme. So he stepped out briefly, but he's with us today. I'd like to also welcome Dr. Amina Dorai, my sister, country director for Pathfinder. You are welcome. I'd like to also acknowledge and welcome the Deputy Chief of Staff to Osun Governor, Honorable Abdullahi Binyuho. I'd also like to acknowledge Dr. Nneka Onwu, who is representing Dr. Faisal Shuaib, our Executive Director, MPH-CDA. And finally, I'd like to also welcome Dr. Dayo Kusa,
who is the Independent Conflict Transformation Strategist, Abuja, the first National Assembly correspondent of Guardian newspaper. I think it's important to mention that because we have a lot of media partners here today who we haven't yet acknowledged, but as we know, the media really is the fourth estate. And the media, thank you for being here. You all play a critical role in keeping Nigerians informed about health and everything that we need Nigerians to be better informed about, and for always reliably turning up at such events. This is a very important forum this morning, and it's good to have your presence today. I'd like to start off with welcoming a few of our guests to give their goodwill messages, starting off with the representative for the Nigeria Governors Forum. So if you could please come up and we can start taking some of the goodwill messages so we can get on to the main thrust of our program today. I know we're running a bit behind, but we will try to make up as much as we can for last time. So do we have a representative for NGM? Thank you very much.
Good morning, Your Excellency, the Deputy Governor of Nasarawa State. I believe the MC has established some protocol. So as I like to always quote the Honorable Minister of State for Health, that we shouldn't be standing on protocol, but we should be aligning ourselves with protocol. So I'll try to align myself with the protocol that has already been established by the MC, I hope. And my name is Dr. Ahmed Abdul Wahab from Nigerian Governors Forum Secretariat, and I'm representing the Director General of the Nigerian Governors Forum. The DG will have been loved to be here, but you know, we are now towards the end of the year. There are a lot of clashes of activities, and so he actually asked me to come and deliver his goodwill. But he had a very good chat with Antimoji and the team in the office, just to show the commitment of the Nigerian Governors Forum Secretariat to this movement. So the DG actually asked me to send 3 messages to this forum. The first message is the DG sends his congratulations to the summit group, that this is really a very important summit. And the idea that this summit was actually conceptualized and is being implemented by a Nigerian-led group is something that I think we're aligning with the national anthem of the country, that's Arise for Compatriots. So we're having our compatriots rising to the occasion of trying to ensure that no one is left behind, and we're having this push. So the DG sends his congratulations that this is something that we should be very proud of, and he would like to actually congratulate the organizers of this summit for this very unique and wonderful idea. The second message from the DG is that we'd like to assure the summit group that UAC is actually one of the priorities of the Nigerian Governors Forum Secretariat. And so organizing this summit actually is something that the Secretariat is very, very committed to. And I would like to assure the summit that the Secretariat will look forward to whatever it is going to come out of this summit, and that will be committed to whatever that comes out from this summit. And then finally, the third message that the DG is that this summit should be different. Already, as mentioned by Antimoji, this is a different one because it's a Nigerian-led initiative. But more importantly, that it shouldn't just be a one-off event. We are going to be engaging, we need to engage with the political class. By next year, there's going to be a flurry of political activities. And that is when the importance of this group will actually be highlighted because we need to engage with the political class. And so not just this summit alone, but by the time we finish today, this today is just kickstarting the process. But what is very important is what will happen after this summit. And it shouldn't just be an idea that is going to stop in Yaradua Hall, but something that after we must have finished today, we'll be able to kickstart the process and start engaging with the political class. So, and I'd like to assure you that Nigerian Governors Forum is solidly behind this movement, and the forum looks forward to the outcome of the deliberations here, and then we'll also be with you as we move on this movement to actually make sure that we leave no one behind and make sure that UHC is very high on the political agenda. Thank you very much.
Thank you for that goodwill message, Dr. Abdul Wahab, on behalf of the NGF, National Governors Forum. I'd like to now welcome a member from the National Assembly, to give a goodwill message. And we have Honorable Dr. Abubakar Yunasa Ahmed, who will come up and give a goodwill message on behalf of the National Assembly. You're most welcome, sir.
Bismillahirrahmanirrahim. The chairman of the occasion, I have to crave your indulgence to permit me to stand on existing established protocol. Good morning, everybody that is here. Universal Healthcare, UHC, whatever it is called, we are all here for it. Or they call it Universal Health Coverage Intervention for the Nigeria Program. A very thought-provoking program and a very incisive one for that matter. Forget, I have kata, so I hope my words will be loud, they could be heard. When you look at the introductions and the preamble, part of the aims include, but does not limit to, policy makers committed to investing in universal health coverage, meaning to get them engaged. This is part of the objectives of this NGO, a quite commendable one for that matter. When you look at the situation here, we in the National Assembly, thus so far that have been coming, knows some of the problems that much of the people outside the National Assembly couldn't actually understand. What I'm trying to say here, I want to be a little bit very, very modest, because the 8th chairman of the National Assembly, the 8th Senate President of the National Assembly is right seated in front of me. That's why when I started, I was fumbling. The issue is, during the 8th Assembly, much has been achieved for this primary healthcare delivery under his watchship. Why? Because he is, and he will be, continue to be a medical doctor. What am I trying to insinuate here? We are now in a democratic regime. Our Constitution 1999, even through today, with the first alteration, second alteration, third alteration, and we are now about to witness the fourth and the fifth alteration. The last fourth alteration was in 2017. Has been, as it is amended, has adopted democratic governance as the means of governing our people. Has also section 14, subsection 2, A, B, C, has defined the role of governance. B, has fundamentally mentioned what will be the primary objective of governance. Then section C has called for citizenry participation. Pursuant to that section, how much are the health practitioners, health professionals are taking due advantage of this scenario, either individually or collectively, by trying to enshrine that all strata of government, right from the local government councillors, chairmen, state assembly, state governors, national assembly reps, senators, and even including the governors and the president. What effort individually, collectively, the health practitioners are trying to see that they are adequately represented. Why am I saying that? The policy makers are health practitioners, but those who will provide the legal framework using the instrumentality of the authority of the law are the National Assembly members. Now talking naturally, how many health practitioners have been sponsored individually or collectively to the National Assembly to do that work for you? Our first Prime Minister, Sir of blessed memory, says, when you don't blow your trumpet, nobody blows it for you, for everybody is busy blowing his. Medical practitioners, wake up. Thank you.
Thank you very much for that goodwill message, Honorable Ahmad. I'd like to now welcome the representative, Country Director for the World Bank, Dr. Tikabe Balai, to give his goodwill message on behalf of the World Bank, a formidable partner to Nigeria continuously. You're welcome, Dr. Balai. Thank you.
Good morning, everyone. I will stand on existing protocols. And then I really want to congratulate the organizers of this forum for a number of reasons, especially that taking the political process as a milestone, a corner milestone for really increasing the discourse on UHC for Nigeria. I just want to say 3 points as an entry to remark to this discourse. The first is really the importance of universal health coverage for the World Bank, which I'm representing. As you know, the World Bank mission is really eradicating extreme poverty globally. And we know globally, every year, 100 million people fall into poverty because of out-of-pocket spending for healthcare. So as you can imagine, UHC is really a main vehicle for the World Bank in addressing really poverty. The second I want to make is really the importance of measurement. Really measurement to understand what progress we're making, especially for Nigeria. When we have UHC discussion, either politically or technically, it's important we ground it on the evidence. We have the evidence where Nigeria is, where it has been, and where it's going. And in this regard, and we have really a good tool that came out, for some of you already might have seen this, the Global Monitoring Report that was published by the World Bank and then WHO that came out this week. And this is a global report. And then it measures UHC, the 3 dimensions of UHC. The measurement is not perfect, but still something that would give us an evidence to assess our performance. Nigeria in this really report, Nigeria is in the low to medium on service coverage indicator. That means out of the 3 cornerstones of UHC, the service coverage, Nigeria is not doing that well. But at least we know 10 years ago where Nigeria was and now where Nigeria stands. And it's important that we measure this in country and the measurement across different states so that at least we will know where the most progress needs to be made. The third point I want to make is really the next step from this forum. And that is really the critical thing that I see. 2 things that I really want to stress. One, is there a clear pathway that we all, at least those of us who are working in Nigeria and the Nigerians, that we all agree in terms of pathway towards UHC for Nigeria? And I've been working in Nigeria some time back, and then since 2 years ago, so I really have to see that consensus, a clear pathway towards UHC. And there are a number of countries from which one can learn, but there are in-country small pilots that Nigeria can learn from itself. And one of this is this progressive universality where we all know not everyone equally needs medical services or equally afford medical services or health services in general. So there are ways of really focusing on those who are at the bottom of the society and progressively work upwards to cover the rest of the society in terms of towards UHC. That is just one pathway. But there should be a political consensus. This is what this forum might really lead to. So it's really, my hope is this forum, the next step of this forum is really to push the consensus towards a clear pathway towards UHC for Nigeria. Thank you very much.
Thank you for that goodwill message, Dr. Tekebebelai. I think you have kind of led us into what will be the next few sessions where we really get under the skin of getting us as a country to UHC and also some of the models that other countries have employed to get there. When we think about UHC, the acronym UHC, 3 letters, but you know, what does it mean on a very basic level? It just means that everybody has access to healthcare and then they're not financially made worse off by it. And it's something that every person, Nigerians, rich, poor, whatever, has and should have access to. So I think as we go into technical sessions, we will probably learn a bit more. And especially given we have very distinguished guests here in the political leadership, we can get them on board as well to understand some of the challenges that we encounter in Nigeria and how we can get to where we want to go. Our next goodwill message will be delivered by the representative from FCDO, Dr. Sam Abo. If you could please come up and let's hear your goodwill message from FCDO. Thank you so much.
Your Excellencies, I stand on all existing protocol. Thank you very much for having us today. On behalf of Katrina Liang, the head of mission, I'm pleased to join others in congratulating UAC 2030 Forum for organizing this seminar. Again, to say very clearly, we know what Nigeria was 30 years ago. We also know what challenges it's been through in the last 2 decades. Having said that, globally, the UK government has been pushing for 4 items in terms of supporting not only Africa in the Asia, but in the 192 countries we work in. And the 4 areas are: first, we're very concerned about the global health security. And again, it's very important that this is on the agenda today. Secondly, we also are promoting access to COVID vaccines, diagnostics and therapeutics. And in the last 6 months, we've supported Nigeria in trying to get their genomic sequencing in place, and the capability and capacity has increased from less than 400 sequencing that was being done before to over 2,000 now. We'll continue with our mandate in terms of looking at ending preventable maternal and newborn deaths. Again, this is a major issue in Nigeria, where if you look at some key northern states having more than the national average. And through our Lafia program, we'll continue to support to make sure that not only climate resilient health systems are in place, but we'll work with both national and subnational governments to see how the people are engaged, mobilized, and own the program. And like my brother Tekabe said, this will not just be a blah, blah, talk and talk, but we have to work that vision with actions. In clear terms, the people must also be engaged to participate like they participate in politics. Health is the right of everyone, and we'll continue to work with the forum to see how we cascade this down to the communities, because at the end of the day, we talk about people, political commitments. People are politics. People are politicians. People are policymakers. So the people must make that change if Nigeria is to progress. So again, to congratulate you for hosting this lovely and timely meeting, but we want to see the next steps in terms of cascading down to the communities. I thank you very much, distinguished ladies and gentlemen.
Thank you very much, Dr. Sam Abo. I think when you say escalating it and cascading it down to the communities, I think all of us here as health advocates in the CSO space, that really is a lot of the work that we have to do and a lot of the work that we do, informing Nigerians and empowering them with information to know that they have a right to demand for healthcare from their political leadership. And in demanding that right, we have to equip them with the right knowledge and information at all times and keep them engaged and find forums to also listen to their perspectives and their voices in how they access healthcare in Nigeria. So I think as CSOs and NGOs, that really is our work cut out for us to ensure that these kind of forums go into the communities and then not just left here in these types of forums, but actually lead to action. I'd like to welcome our next goodwill message, and then we'll get down to the technical sessions. It's from Dr. Yusuf from the Bill and Melinda Gates Foundation. If you could please come up and give your goodwill message on behalf of the MGF. Thank you very much.
Like with my previous colleagues, I would like to align and stand with the existing protocol. My country director, Dr. Jeremy Zongrana, would have loved to be here himself. Unfortunately, he's out of the country. But to start to say that the Bill and Melinda Gates Foundation goals in Nigeria and globally is fully aligned with the aspirations of this summit. As you all know, the Gates Foundation believes in the creation of opportunity for people around the world to live healthy and productive life. And we feel that this summit is fully aligned with our goals, and we are happy to be associated with this summit. We in the foundation also feels that the current performance of the Nigeria healthcare system is not a true reflection of the capacity of the Nigerians and indeed the Nigeria healthcare system. And therefore, forums like this that tries to galvanize momentum to change that narrative is fully aligned with our vision in Nigeria. As we all know, the Gates Foundation has been in this country in the last 12, 13 years, and our work has revolved around strengthening, first, polio eradication, strengthening routine immunization, and primary health care. Primary health care is critical to UHC. For us to achieve the goals of universal health care coverage, we need to strengthen primary health care. And of course, 80% of Nigerians live in the rural areas. Without a strong and functional primary health care system, there is no way we can achieve that. The foundation also believes that the achievement of the goals of UHC will save life, will help people live healthy and productive life, and lift people out of poverty. And based on this, we fully support the conduct of this summit. We are fully aligned with the vision and aspiration of this summit, and we will work with government partners, the civil society, to achieve these goals. We assure the organizers of this summit that we will do our best, we will work with you to really push the frontiers forward. We will expect that at the end of this, we would want to see a clearly articulated engagement strategy that first makes health agnostic of what political system is in place or what political party is in power, so that we all align to really help people and lift them out of, provide the opportunity for them to live healthy and productive life and also lift people out of poverty. We are fully aligned with this and happy to support this summit. Thank you.
Thank you very much, Yusuf, on behalf of the Bill and Melinda Gates Foundation. I'd like to acknowledge the presence with us today of our chairman, Senate Committee on Health, Dr. Oloribe. You have always been a huge champion of universal health coverage. So you are welcome in joining us this morning. Good morning, sir. Good to have you with us today. Okay, so we're almost through with our goodwill messages. We have just two more very quickly to go through, and then we can now get on to some of the main presentations. I'd like to welcome Dr. Otun Adewale, the National Program Lead for Wellbeing Africa Foundation, to give us his goodwill message on behalf of Her Excellency Torin Saraki. Thank you.
Your Excellencies, please permit me to align with the existing protocol. Good morning, all distinguished participants and stakeholders. I am Dr. Otun Adewale, the Country Program Director for Wellbeing Foundation Africa. I'm representing Her Excellency Toyin Saraki, the founder and president of Wellbeing Foundation Africa, which works to improve health and well-being outcome of women and infants and children, and towards establishing accessible quality healthcare across the entire socio-economic spectrum and healthcare continuum. Thank you, Chief Mrs. Maponjola, for the invitation today, and to all those attending this significant and timely summit to share recommendations on how we can improve lives and outcomes of our most vulnerable people through universal health coverage. Currently, at least half of the world's population still cannot obtain essential health services. In Nigeria, with our estimated population of 206 million, less than 3% of the population is covered under the NHIS scheme. This extreme unmet need for essential health services makes the pursuit for universal health coverage an urgent priority. With courage and determination, universal health coverage is within reach. Reflecting on the nation's journey from the Astana Declaration for Primary Healthcare, the Abuja Declaration for Basic Healthcare Provision Fund, and the need to deliver daily wellness to community in the era of COVID-19 pandemic, as well as the ongoing strengthening of specialist tertiary level facilities, it is clear that we must not forget to invest in meeting the needs of the primary healthcare delivery at the community frontline level. Global donors, civil society partners, and private sector to date have shown their willingness, dedication, and transparency to engage in Nigerians' journey towards universal health coverage, as exemplified by their commitments by the committed actors, ranging from Coca-Cola Saver Beds initiatives to the ongoing OSAP SDGs to establish 100-bed mother and child referral facility across the nation. So this Liverpool School of Tropical Medicine, a five-year WBFA program, which was to improve the availability and quality of maternal health services in Kwara State. So the program going on in Sokoto and Kano State, being sponsored by the government of Canada through the Nutrition International, so reducing the diarrhea, maternal, sorry, I take that again. So reducing the diarrhea disease in Sokoto and Kano State. So WBFA Medela Cares, working partnership to improve breastfeeding in NICU across Nigeria. However, this reveals that our impact and progress is donor dependent. We must work towards domestic resource mobilization transparently, measurably, and accountably. Learning from the success and challenges of my Wellbeing Foundation Africa 2011-2016 5-year Alafia Universal Health Coverage Fund Program, which provided health insurance capacitation micro grants for 25,000 Nigerians in Kwara State. In support of the Kwara State government, Farm Access Agile Community Health Insurance Scheme, I am reminded that the umbrella of achieving a universal duty of care delivers and frontline demographic data goes beyond the impact of innovative health financing. The top 5 conditions recorded in the utilization of AUHCF beneficiaries were malaria, pregnancy, fever, cough, and hypertension. Yet to mention, yet so often, national and global policy decisions were simply do not make it effective to the front line where lives were born or lost. We must try harder to match the intelligence and knowledge of frontline communities with global innovations. The Declaration of Astana, unanimously endorsed by WHO member states in 2018, makes pledges in 4 key areas. 1, make bold political choices for health across sectors. 2, to build sustainable health primary health care. 3, and to empower individuals and communities and align with stakeholder support to support national policy. WBFA is optimistic as we discuss building political will for health center decision making towards the upcoming 2023 election and policy window. As through our work in Nigeria, we have seen firsthand our civil society organizations, health professionals, private organizations, and indeed legislators taking on the challenge of universal health coverage with enthusiasm. We must obtain firm commitment towards enhanced prioritization of health policy in party manifestos and government spending so that Nigeria can chart a course of action which will set the country on a trajectory of obtaining accessible universal health coverage. The WBFA commend today's critical dialogue on universal health coverage and look forward to closely following the proposed solutions and commitments which we emerge. My call is now for action. We must act to ensure that every person, rich or poor, living in cities or rural area can access quality healthcare. Thank you.
Thank you very much, Dr. Adewale, on behalf of Her Excellency, Toyin Saraki. Okay, so we have one final very brief goodwill message on behalf of civil society representatives, and that is from Anu. Anu Rotimi, are you here? And then we can now go on to the main thrust of our program. So very briefly, because we are a bit short of time now. Thank you very much.
Good morning, everyone. Kindly permit me to align myself with the already established protocols. Today, we are very excited as civil society and on behalf of the Human Capital Development Network, that we align with the vision, the mission, and the purpose of this summit, which actually intend to place the issue of health at the forefront of political agenda. With the focus to mobilize and strengthen and sustain political economics for health ahead of the 2023 general elections, it's important to emphasize the importance of getting the conversation right, which this event is all about. The Human Capital Index, as defined, is a measure of how much human capital can a child born today expect to acquire by the age of 18, given the risk of poor health, poor education, and livelihood that will prevail in the country where he or she lives. Following the first assessment in 2018 by World Bank, which ranked Nigeria 152 out of 157 countries, our dear nation 2 years after, by 2020, recorded an Human Capital Index score of 0.36, indicating just 0.02 improvement. This means that any child born in Nigeria will today just have about 36% as productivity level compared to any other child who enjoy complete education and full health. And meaning that only about 88 children out of 100 will likely live up to the age of 5. With this in mind, we stand here today on behalf of civil society to say that we hope that the governance and political agenda will create and sustain enabling environment for people, especially mothers, children, to acquire the knowledge, skills, and health they require to realize their full potential in life and as productive members of this country, Nigeria. We wish to call on the stakeholders, especially the political class, to invest, own, and sustain a health system that will leave no one behind. We are assured that this discourse today will enable our political leaders, political parties, and citizens to deploy their influence and resources to place health at the front burner of the 2023 political agenda and even beyond as a means of driving an economically viable nation. That we hope and we envision in our own lifetime. Thank you very much for listening, and we wish the entire summit a place of deliberation. Thank you.
So thank you very much, Anu, for that goodwill message. If you look at our agenda, we're supposed to have distinguished Senator Ibrahim Ololega take the first goodwill message. Is the chair, Senate Committee on Health, and is also the chair of the Legislative Network for Universal Health Coverage, which is a body that brings all lawmakers together to look at the issue of health. So the pleasure is mine to invite distinguished Senator Ibrahim Ololega to the podium. What is sir?
Your Excellencies, distinguished ladies and gentlemen, I also, just like previous speakers, wish to align with all the established protocol. I'm very pleased to be here today and to give this good message. Before I became elected again, I was part of the society in the last 15 years. And I recall what is being done today. We did similar things in the year 2003 under the Change Engender program, where I was privileged then to be the lead champion for health policy and health legislation. And preceding the 2003 election, we came together as state agents to write letters to all the then political parties. I think there were about 31 of them that contested the 2003 election. And I would say we achieved some results, because the effort of that period led to the re-elected President Obasanjo to appoint the leader of the Change program then, Professor Ita Lambo, as Minister of Health. And if we all recall, the period 2003-2007 was very good for the health sector of Nigeria. We had a lot of reforms that happened to the health sector, including the review of the national health policy, including then the drafting, the first draft of the National Health Act, which we could say is the ground norm for health in Nigeria. The first draft of that act was presented to the Federal Ministry of Health and then to Federal Executive Council in 2004. I was privileged to be the one that laid that. But unfortunately, I would say, it took 10 years before the act was passed, and we are part of the group. So what I want to say is that what we are doing today is not new, but it's something that we require because between 2007 down the line, most of the reforms that were achieved in that 4 years period were being turned back again. If we recall then, between 2003 and 2007, we had increased allocation of resources to health. We had a lot of policies that were put in place. But what is good now is that I'm very grateful to God that I have this particular opportunity. Because with the opportunity I've had to be in the Senate and to be privileged to be placed in charge of health, we have picked up the mantle again. The Basic Healthcare Provision Fund, which was put in that National Health Act that we drafted in 2004, passed in 2014, but actualized in 2018, had a guideline that was drafted. When we came in, we found out that that guideline was not in line with the vision of the act that we drafted in 2004 that we passed. Because some partners came and they wanted to usurp our national sovereignty, we have since then redrafted that guideline under the leadership of the Federal Ministry of Health with us as National Assembly oversighting on it. And now we have a new guideline that tries to look at our federation, but we are not yet there. The Basic Healthcare Provision Fund, we have so far been able to have a release since 2018 to now. About a few weeks ago, when we were having the budget, we drilled the Ministry of Health to be able to provide us with information. And we saw that it's only 2018 and 2019 fund that has been released and being utilized. But the other ones are there, they are ring-fenced. One of the reforms we're able to achieve under the Basic Provision Fund so far in the last 2.5 years is that we have now removed it from service-wide vote into statutory release, in which case it is absolute that whatever amount allocated to it, which is the minimum of 1%, is fully being released by Federal Ministry of Finance. So that's one of the things we are able to do. And we are pushing on to get the Basic Healthcare Provision Fund to be released. Now, the constituency I represent, which is the National Assembly, jointly together, just like the MC has said, we work as a team in the health sector. And I happen to have the privilege of being the chairman of the joint committee. Under that, we have had some kind of innovations that we have brought into health. One of which is the National Health Insurance Authority Bill, which we have passed since last year, but in the Senate, it was passed in the House of Rep this year. It was presented to the President for assent. Unfortunately, the President did not assent to it. But because of our push, we have recommitted that bill and we have repassed it again with taking on board the observation. I noticed that the ES of NHIS is here. We've been working together closely. It's part of the collaboration we are doing. And we have made the President is willing to sign it now. The House of Rep should be doing their passage next week, and it will be transmitted to the President for assent. The President is committed to getting that NHIA signed. The importance of it to what we are doing today, which is universal coverage, is that for the first time, health insurance will become mandatory for all the Nigerians. For the first time, if that act is passed, we are going to have vulnerable group fund. The issue was that we created a specific tax, the tax that is taxing 1 kobo per second of communication bill to fund the vulnerable group fund. But the Federal Ministry of Finance raised the issue that a sector cannot just create a tax. But what we need to do is to be able to get the funding from the tax, and that we should do that through Finance Act. But we have instead created a special fund for vulnerable group, which will be funded just like the Basic Healthcare Provision Fund. Our fish is that let's start from what we call low-hanging fruit, and then we can take it forward. So I want to assure us that if to be able to achieve health coverage, we need the health insurance. I'm not speaking for the NHIS, but I'm sure it will come up to say it, because the essence of health coverage is for everybody that requires health to get health at the point of need without suffering any catastrophic whatever, particularly financial. So both all the assets, that is the assets, physically, in terms of the transportation to be able, access to be able to get to the facility, access to access the care, and access to quality service. This can only happen if you have a universal payment mechanism. And the only way we can have that is if you have access to insurance for all. It is my hope that part of what we need to achieve collectively after this is to get that act to be passed, to be signed, and to be implemented. We don't want it to be like then the National Health Act that took 10 years or that took 4 years to be implemented. Our hope, which is what we are pushing, is that the federal government and the president before he leaves, which is committed to it, will launch the vulnerable group fund and will ensure that every Nigerian, particularly those 70% that are vulnerable, have access to healthcare. Now, finally, if my remark will also include, in terms of what I want us to discuss here, we need to rethink about public financing, public funding of our healthcare, looking at our physical structure. It's a federation. The federal government, we have the federal government, state, and local government. If you look at what is happening now, the sub-national level are not committing as much as necessary to help. And the National Health Act stated the responsibility for each level of government, with federal having more responsibility for tertiary care. Of course, 70% of the federal budget for health go to the teaching hospitals and federal medical centers, but of course, most of that are for salary purposes. But the federal government also commit through the Basic Healthcare Provision Fund, as well as through Primary Healthcare Development Agency, substantial amount of funds to fund primary healthcare. But what we do see is that many states are now doing what we call replacement. Instead of them allocating their own resources to that, once they see the Basic Healthcare Provision Fund coming, or things coming from National Primary Healthcare Agency, states don't allocate as much resources as they should. We need to rethink this, because without us taking care of the primary healthcare, which is the base, which is the big base, I would say, or the foundation, whatever federal government is spending at that level will not have effect. That's why we see in many of our teaching hospitals, instead of them concentrating on the specialized care they are supposed to provide, what they do mostly, you see the general things that they do. So we need to discuss this one. How do we get a subnational level to do this? But we can't do this in isolation without looking at our physical structures well, because federal governments take larger share. So we need to, that's why the issue of about, when we talk about restructuring, you should also look at fiscality. Because if you have to fund health, the funding should be equitable to the responsibility that is given to each level of government. So I'm throwing this out that we need to think through, how do we improve coordination and collaboration between the national and the sub-national level in terms of funding and delivery healthcare? How do we improve the linkages? Because the primary to the secondary and tertiary must have effective linkage so that we'll be able to achieve effectiveness and efficiency. I wish us successful demonstration. Thank you. God bless.
So thank you very much, our distinguished Senator Oloriegbe, for that very important remark. A lot of important takeaway there, but we're happy that the National Assembly is working on the vulnerable fund. We need to expand the fiscal space. And secondly, the lingering issue of the political economy in terms of roles of different tiers of government are very important. So, and I would like to thank all that gave a goodwill and message. Now we'll be going to the technical section of this event. And to start the technical section, the most important principle in development is think globally and act locally. So for us to be able to think globally, we'll be inviting our global think tank, the friend of the country, the international global think tanks that have been doing a lot of work to set policy direction globally and harness the learning from different countries to be able to support country to know what to do differently to achieve universal health coverage. So we have a collaborator in the Chatham House in the UK. Their Center for Universal Health Coverage. The only thing they do is the political economy of universal coverage. While we are setting up the technology for our colleagues from Chatham House to join, let me quickly introduce two of them. One is a Nigerian, part of us, and the other is a friend of Nigeria. So let me start with a friend of Nigeria, who is Robert Yates. Robert Yates is a global figure when it comes to universal health coverage. It's a political health economy specializing in universal health coverage and progressive health financing. He is executive director of the Center for Universal Health at the Chatham House. He's also an honorary professor at the London School of Hygiene and Tropical Medicine, and a long-time consultant to the elders of the health program. Then, so one of us, Professor Aliko Hamed, is a public health physician, epidemiologist, and global health strategist. He's an associate fellow and the convener of the Public Health Africa Policy Forum at the Center for Universal Health at the Chatham House. He's a regional director of public health for the East of England region. He's qualified in medicine from Ahmadu Bello University, Zaria in Nigeria here, and received higher specialist training in London School of Hygiene and Tropical Medicine and University of Cambridge. He's a fellow of the Royal College of Physicians and Faculty of Public Health. He's a senior fellow and professor of public health at the University of Cambridge and Staffordshire University, UK. He's just received the UK highest professorial public health award, presidential medal before the public health in August in 2021. Permit me to join Professor Aliko and Robert Yates. Robert and Aliko, over to you, please.
Thank you very much indeed, and greetings from London. I'm just checking that you can hear us okay. Are you able to sort of give us a signal that the sound is coming through okay?
We can hear you loud and clear, Rob.
Oh, excellent. Congratulations. Thank you very much. Your Excellencies, distinguished guests, ladies and gentlemen, it's an absolute honour to be with you today, speaking to you from Chatham House here in London. But also a disappointment that we're speaking from Chatham House in London and not with you as we had hoped to be. Really, this was due to the ridiculous travel ban that the UK government put on travel from Africa recently, that sort of kept us, here in the UK. And that's very unfortunate because we were so hoping to be with you, to be there in person. But I'm delighted that technology is working so well. And in the next half hour or so, Aliko and I would like to really discuss the big picture of the political economy of UHC reforms. And so we just have a few slides that we'd like to run through with you. And so just bringing up the technology here. And again, I'll be asking if you can just confirm that you can see our slides. So can you just confirm that the slides are coming through okay?
You can see the slides clearly.
Excellent, brilliant. Oh, that's perfect. Thank you very much. It works a lot better than the technology here often in the UK. We've been introduced already, and I know that we're against the clock a little, so I will sort of rush on if you don't mind. So we are the Centre for Universal Health at Chatham House, the Royal Institute of International Affairs, founded in 1920, so just over 100 years ago, and I think quite significantly founded after the traumas and crises of the First World War, but also the Spanish flu, thinking of two crises that happened at the same time, and I think spawned a lot of this international cooperation. I am the executive director of the Centre for Universal Health, and we specialise in the political economy of health and health reforms, recognising that the transition towards universal health coverage, which of course we all recognise requires public financing and really having a system whereby the healthy, wealthy cross-subsidise the sick and the poor, that is an inherently very, very political process. Every country in the world grapples with how do you bring in that type of health system, in effect a publicly financed health system that provides those cross subsidies. And we provide what I think is a unique expertise in the politics of that process. And that's why we're absolutely thrilled to be with you today for this conference that is really getting to the heart of how do you put UHC reforms onto the front burner, particularly in the run-up to elections. And we've already heard how important elections are in these processes. And so we're advising political leaders in countries of all income levels, even the United States, but all over the world on the tactics that one can employ about how to introduce UHC reforms and how to maximize the benefits, the health benefits, the economic benefits, the societal benefits, but also the political benefits. You know, we need to be upfront that UHC reforms are popular and they win elections. And we need to be very explicit about this. And hopefully that will encourage political leaders, maybe some of you in the centre today, to be considering this in your election platform. We have a long engagement in Nigeria. We have hosted health policy summits, the work that Aliko has been doing with the Public Health Policy Forum. We've had ministerial briefings, I think a briefing that might have even reached President Buhari at one point. We've organized country visits, even to the state level. And of course, we are LAFIA partners, and we're delighted to be part of this partnership, which is all around strengthening health systems in Nigeria, but also engaging in the political economy of these processes. So what we plan to do is just in the next half hour, just to sort of break it down into three little sections that Aliko is going to take over from me now and very much talk about the impact of democracies, you know, the politics of health and health reforms and relating democracy with UHC and health outcomes. I'm then going to focus on what is happening in the world at the moment in terms of UHC reforms, and very much emphasize that the COVID-19 crisis is catalyzing UHC reforms all over the world. And we've seen this before. It's at times of crises that UHC reforms happen. And we're absolutely convinced that Nigeria is ripe for this and are very keen to try and encourage this approach, that one of the smartest things that politicians can do coming out of the COVID crisis is to launch UHC reforms. And then we just want to briefly finish up with a suggestion about how we can collaborate with you in making sure that UHC is top of the political agenda in Nigeria, both through the elections and, of course, most importantly, after the elections as well. But I'll hand over to Aliko now, and I'll keep running the slides.
Thank you very much, Rob, and thank you very much, everyone, for the invitation. The last time I spoke to Nigeria, I think the issue was how you said protocol observed. I think the new one now is protocol aligned. So thank you very much for the invitation. We're really delighted to be here. I'm supposed to talk a little bit about democracy and health. And I think the conventional wisdom that we all accept is strong democratic institutions can improve social and developmental outcomes in liberal democracies. We know a lot about that. The key question for today perhaps is, does democracy really affect population health? In other words, does your vote affect how long you live or how long your family and you live? So I think that's what I will want to explore briefly later on, and Rob will go into more specifics with different countries. But before I do that, I think talking about health, Rob, the next slide, please. Talking about health, I think it made me to reflect on the last few years or 2 years particularly of our lifetime, COVID pandemic. I think the last 2 years has been extremely challenging to humanity as a whole. COVID exposing and exacerbating vulnerabilities, fragilities within all of our society, particularly in some low-income countries. We've lost and still losing a lot of friends, families, colleagues, and a lot of humans across the world. What is interesting is at the early part of this pandemic, when there was gloom, darkness, and hopelessness everywhere in the world, there was a sense of collective solidarity in its mitigation. Next slide, Rob. As we now move, seeing the light into the horizon, when we are seeing some sort of opportunities for getting back to normality, unfortunately, we are seeing some practices across the world that is not only unethical, but immoral. And I think it is time that African leaders such as yourself continue to emphasize the need for equity. The global health inequities we are seeing with vaccine is really, really not acceptable. and I will really urge us all to work for that. Effort to enhance diagnostic capability for COVID is welcome, but that should be matched with interventional accessibility and urgency. Humanity is one and the same. So I just wanted us to reflect on that because it's not yet done. Rob, can I go to the next slide, please? So the key question that I wanted to just answer a little bit is, what do we know about democracy and health? And I'm glad my World Bank colleague has talked about measurement. Because it is important when you are assessing that, we think about how do we measure it. It's a conventional wisdom that health is much straightforward because it is rational, it is scientific, well-being, prevent death. And we have very clear measures for that, such as mortality, whether in children, mothers, or related to particular diseases. We also have aggregate measures such as how healthy or unhealthy populations are. What is slightly different for some of us is how do you measure democracy, especially taking into account that politics in itself is a subjective and normative enterprise. You have a range of different political regimes, economics around the world, and therefore when it comes to an assessment of what is political progress, there will be some sort of disagreement or rather lack of agreement collectively. Fortunately, we have the University of Gothenburg's Variety of Democracy project. So this is an important project that has really, really been helpful to global democracies in understanding what is being made as progress and what hasn't been. And just to say a little bit about that for those who might not be too familiar with it, it's a project that has a database that includes a huge amount of information from free elections, electoral processes, how countries allow freedom of association for media, expressions, and even issues about women's rights in terms of voting and other social libertarian views on it. It has a huge database that covers more than 200 countries around the world, and it has data ranging from about the late 1700s, so a huge amount of asset. Within this database together and create an index or an aggregate measure, the one that is globally used now, generally accepted to check whether there are democratic experiences, is called the Liberal Democracy Index, the LDI. So for most studies that look at democracy, LDI is the key indicator, just like we look at life expectancy when we're looking at other countries. So just a bit of an insight so that when I show the few other studies, you can see what I'm referring to. Over the last few years, there has been a huge amount of evidence that has accumulated on democracy and health. But I've just been given less than 10 minutes, so I will not be able to go through all of that. What I can try and do is to just highlight some of the key findings from some of the most robust and recent studies. Rob, let's go to the next slide. So this is the first one that I think it's fair to look at it. This is from the work of our World Data, which is a very useful site and project that is going on from Oxford. And this is showing the correlation between life expectancy, as I say, the measure of how well and healthy a country is, versus the democracy index, which is how good your democratic experience is. It's a correlation, not a causation, as we look at it. It's a continuous variable with the x-axis, as you can see there. What that is simply showing is countries that have better democratic experiences, so especially those on the extreme right, upper top there, you can see that they are enjoying life expectancies that are more than 72 years, while at the bottom side, the less of your score with democratic experience, and then the lower your life expectancy. So the key message here from this study is essentially is a good democratic experience is more likely to allow you to live longer and have an enjoyable life for yourself and your family. So a very important evidence that we have that just shows a positive correlation. Rob, if we go to the next one. The next one that I wanted to show you was from a study of Boyke. Rob, is that the next one? So this is one of the most comprehensive studies that has been done recently. It's published in Lancet, actually, and it's assessing the relationship between democracy and death from about 170 countries around the world. And it covers a period of 45 years, so from 1970 to 2015. And what it does also is included countries that are recently transiting into democracy, especially from Eastern Europe, and compared them with autocratic nations that are around the world. For those of you who can see it there, you can see Nigeria was not included in that study, unfortunately, even though it is the largest black democracy in the world. But I hope is that Nigeria as part of that study, because we have a huge amount of democratic experiences, and I hope it will be one of the outcomes that we can take forward from this session today. Let's then go to the next slide to say, what does the study find? I just summarized this one. On the left-hand side, it's a comparison from democracy to autocracy. And then the red ones, we took a very simple measure of health, HIV-free life expectancy as a good measure. The dotted line you're seeing in the middle is when democracy sort of was considered in those countries when the transition are. Most of those countries are in the Eastern Europe, so about 15 or so of them, compared to about 54 that were considered autocratic up until 2015. But the key finding there, you can see the power of democracy there. Life expectancy in those countries that transition into democracy increases immediately after the transition. And that increase continues well over time, while you can see the fall in those other countries that have not transited into democracy. So another element to say that we need good political leaders who understand democracy and who are committed to democratic principles, because that in itself will determine how long we and our children live. The next one on the right of that one is also another evidence that just shows how democracy relates and affects diseases particularly. And you can see some of the biggest killers of that we have in even Nigeria, or rather in most parts of the world: cardiovascular diseases, road traffic accidents, among others. And in summary, what that is showing is if you are a democratic country, you are more likely to reduce your death from those ones compared to countries that are not enjoying democratic principles. Another thing that I think is very helpful to see from this is a strong relationship between free and fair elections in terms of how it affects death within the country. What that is showing, you can look at the different variables. The shaded light, the free democracy is a sort of, you add the model together, then you remove one and see what's the effect of the others. When you take into account the lack of free and fair elections, almost all the gains you get by reducing that disappeared. So in other words, if you want to really improve your health, free and fair elections are important, which are effective our political processes are, particularly the political leadership and the governance of it. One of the things that came out from this study also that was really interesting was the notion that if you are a rich country, you are therefore going to be democratic or you have better health experiences, which we know is not the case. What this study has shown in particular is that your GDP per capita, which is your national income, is not related to your democratic experience. It's your government spending on public health. In other words, how much you allocate your resources for public health services. And we all know that that is a political choice. Next slide, which is showing then how do democracy affect public spending. And most studies we have looked around the world actually shows that the more democratic nations, the more they increase their public spending for good. Quite rightly so, because they are more open to challenge, more open to scrutiny, more open to particular criticisms if they don't determine their effectiveness. And democracy allows for that. This is a data from the World Bank Governance Project, and it shows the indicators of how good democracy and public effectiveness of government is. And that is this is about making that difficult choice on how they redistribute their resources. And that is a political choice, as I said. It is not how rich the country is. It is the political will of the leaders of that country to determine whether resources have been allocated for, and China and many other places that are considered to be different from what the liberal democracy says proves the point. I think I would like to just go to the last slide just to highlight some of the key points. Then Rob will take us into specifics into countries. Rob, can you put the next slide, please? So what I'm saying is most of what we find in the studies are looking into election and health are absolutely inseparable. You cannot have that. And fair and free elections are important, and that depends on the degree of which our political leaders' commitment and their will to make a difference is. With no resources at all, or lack of resources, Rob will give us an example of that. Last and not the least, things that they have always wanted, which is better health care, and allow you the opportunity to put a lasting legacy for your own people. So I will stop there. I have only a few minutes. Rob, over to you.
Thank you very much indeed, Aliko. And I'm afraid that the sound was breaking a wee bit there, and I hope
Rob,
that
you're on mute.
Oh, I don't think I am. Can you hear me now?
I can hear you.
Good, excellent. And I think there was a little issue about sound quality there, but I'll just carry on. And thank you very much indeed, Aliko. That was wonderful. And I think you very much showing the very strong relationship between health and democracy and health, and how they relate to each other. And of course, you are approaching elections, a democratic process in Nigeria, where I'm absolutely sure that health is going to be a major issue. I really want to sort of flag to you this idea that actually it's the COVID crisis, this health crisis, that is potentially going to be extremely important, I think, for the population and for political candidates going into the election. Because you can see that right across the world, the COVID crisis is sort of creating political instability, really, around people needing to access health services, needing financial protection. It's affecting everyone in the country, and a recognition that you need universal entitlements. You can't have a situation whereby some people are accessing vaccines and getting treated when they fall sick and other people aren't. And people really want to see results quickly. Politicians are being judged on their COVID responses and the way that they're dealing with the health sector. which I think is sort of quite unusual in the last 30 or 40 years or so, that people are really being scrutinized to see how well they're doing in health. And because what is required is a universal approach, everyone getting the health services they need with financial protection, that is the definition of universal health coverage. So you have WHO Director General really saying that universal health coverage is the route out of the COVID crisis. And what we're seeing, of course, is that some leaders are rising to this challenge and are taking this seriously, and I think are likely to benefit from it electorally. And some, perhaps most famously Donald Trump, who spectacularly failed to protect the American population and was even encouraging people to inject themselves with bleach, have now been voted out of power. And I think this is a trend you're going to see quite a lot of. And so smart politicians who want to be seen to be doing right by their populations, really need to be putting health on the front burner, as we say. Now, I want to also take a historical perspective, and you might say, well, if UHC reforms basically require big injections of public financing, what chance is there of doing that in the middle of a crisis, when economies are being hit hard? And if anything, the evidence from around the world is that, surprisingly, it's just at these times of crises that governments launch UHC reforms. That the slide you're seeing here is the architect of the National Health Service here in the UK, who launched the NHS, the National Health Service, in the aftermath of the Second World War, when the UK was a post-conflict state, when it was dependent on US aid. And even though we were bankrupt, we managed with sort of great public spirit to get the NHS off the ground, to the extent that when we hosted the Olympics in 2012, we celebrated it in the Olympic Stadium. It's one of our greatest achievements in the UK and is by far the UK's most popular institution. So it can be done in a crisis. Japan, likewise, that their economy was hit even harder. I mean, obviously they lost the Second World War, but rebuilt their economy in the 1950s and 60s and used publicly financed health reforms to provide a social safety net for their population and have become tremendous champions of universal health coverage. This is the former Prime Minister of Japan at a UHC forum in 2017. And I would say that in this sort of G7, Japan's sort of leading the UHC campaign at the moment. They're very proud of what they've done, and justifiably so. They launch UHC coming out of a crisis. Another country that has become very famous for its UHC reforms and holds a big conference every year in Bangkok to justify this is Thailand. And back in the early 2000s, just after an enormous financial crisis in Thailand, the incoming prime minister launched publicly financed UHC reforms, even though the country's economy was in a terrible state. And I think that some of the donors were actually advising against Thailand taking that approach. But the prime minister said, no, I'm determined to do this. This is what the people want. And Thailand have some of the most successful UHC reforms in the world, particularly for their income level. And I think are dealing with this crisis, the COVID crisis, extremely well. But to bring it right up to date, you're seeing that political leaders are learning these lessons, that at times of crisis, it's the time to launch UHC reforms. This is President Ramaphosa in South Africa, where they've been piloting UHC reforms for a decade or so, but are now using the COVID crisis to really get on with it. And you can see that the president here in this news article says they're going to use the COVID response in preparing for the NHI. This is the National Health Insurance reforms. And we at Chatham House are working very closely with President Ramaphosa's office on how this can be achieved. Egypt, another big country, had plans to introduce UHC by 2032, but largely because of the COVID crisis, they're accelerating this now. They're moving this forward, they're rolling it out across states, across Egypt, with a view to achieving it by 2027. And of course, an absolutely fascinating one is the United States, the one rich country that spectacularly has failed to reach publicly financed UHC. But in the run up to the elections, this was a screenshot from a town hall meeting where Hillary Clinton was saying to the then candidate, Joe Biden, don't waste this crisis. We need universal health care. Now is the time for the US to introduce a publicly financed health system. And it's very interesting that the vaccine program that's being rolled out there, totally free, tax financed, don't have to show any insurance cards or anything like that. It's publicly financed UHC. So I think the American population are getting the hang of this now. And there are some state governors who recognize that they have the power and ability and the resources to do this early. And this might be a sort of a lesson in Nigeria that, whereas progress at a federal level might not be what you'd want, that some governors look as if they're going for it. This is the governor of California, Gavin Newsom, who was swept to power really on the back of the health workers unions, promising to bring UHC to California. So watch this space. Will California get there first? And just to illustrate, and this is the point I want to illustrate about the type of support that we do at Chatham House, another country where it seems that the UHC reforms have happened at a state level. This was the then governor of Jakarta in Indonesia, Jokowi, back in 2012. And within a month of coming to power there, he'd introduced a UHC scheme. I've got my card still from this day because I was based in Indonesia at the time. And we did some work with the governor's office and we did some research looking at his reforms and very much encouraged the governor to run on a UHC platform. This was proving massively popular. And he ran for president on the basis of this. And we provided him with a briefing advising him how he could do it. Interestingly, funding it out of cutting fuel subsidies, which I know is a big issue in Nigeria. And just 2 weeks later, in the presidential debate on television, he announced that what he'd done in Jakarta, he was going to bring to the entire country of Indonesia. And it basically won in the election. He is now president, and he is trying to tackle the COVID crisis. Before this happened, though, we continued our support to Indonesia, and through the elders, then chaired by Kofi Annan, advising Jokowi on how he could accelerate the reforms, what he'd need to do to, in effect, implement the reforms that Thailand had done 20 years ago. So it's this type of high-level political support that we are trying to provide and very interested in undertaking this in Nigeria. So looking forward then, and this is my last slide, this is exactly the type of support that we're hoping to provide. And as we've been hearing from the chair, this forum today is just the start of this process. And we're very keen to support you all in accelerating UHC reforms in Nigeria. How are we going to do this? Well, we aim to provide specialist technical assistance and advice on big strategic issues relating to the political economy of UHC. It goes beyond the health sector. This does involve financing, obviously, and politics. And quite specifically, we're all about trying to generate the political commitment for UHC by emphasizing to political leaders the health benefits of UHC, the economic benefits, increased growth and people paying their taxes and employment, etc. The societal benefits, it helping bring fractured countries together. And we've seen that in our own countries about the importance of building a state around basic public services, but being absolutely overt about the political benefits. UHC wins elections, it helps people retain power, and it turns people into national heroes. And potentially there may be one or two of you in the room who've got those aspirations yourselves. So we'd be very keen to talk to you. So we do provide specialist technical assistance on how to launch UHC reforms, how to finance them, how to mount a public information campaign, but also how to sustain them. We can also put you in contact with other leaders who have done this, that through organizations like the Elders, people like Latin American presidents who have launched UHC themselves, the Thai government we work very closely with as well. So we can put you in touch with the real experts who have actually done this. And we can hold public events, join forums like this, join summits, and do things on a public stage and engage the media. And it's wonderful to see so many media representatives today, but also recognizing that this is very, very political. It's very sensitive. We can also, using the Chatham House rules, host private roundtable briefings, either for individual candidates, for parties. We are not party political. I want to emphasize we do not support one party above another. We will talk to absolutely anyone. And in some countries, we're talking to incumbent governments and the opposition at the same time. But it's an open invitation. If you're interested in the political economy of UHC, we'd be delighted to work with you. So thank you very much indeed for your time. I've thoroughly enjoyed talking to you and quite delighted to answer questions. Thank you.
Yeah, I really appreciate a very, very great input. I think a number of important points came out clearly. One is that election and better health outcome are inseparable, but what is very important is the quality of a democratic practice, and that is part of what you are trying to do here to improve citizen engagement in democratic process. And then we have seen several examples of how leaders have been able to win election, the platform of universal coverage. And thirdly, highlighting what Chatham House can help the process in Nigeria so that we can put health on the political front burner. So thank you very much. And later on, we'll entertain questions and clarification from the audience. What you're going to do very soon, I'll go to the distinguished hit Senate President come and share his thought. But before we do that, then after which we are going to for a tea break. I guess the sugar level is going down and we have to replenish. So let me use this opportunity to introduce, recognize the presence of Honorable Babangida Ibrahim, the Chairman, House Committee on Capital and Market and Institution. Do you want to stand up for recognition? Thank you very much. So a slight change in the agenda. Before we go for tea break, like I said, I would like to invite His Excellency, distinguished Senator Bukola Saraki, who, like we know, the president of 8th Senate, the former governor of Kwara State. And I'm happy to tell you, looking at the memory lane, sometimes in 2017, July 25th to be precise, we were at Sheraton Hotel at the launch of the Legislative Network for Universal Health Coverage. And that's where the distinguished made the pronouncement so that I will try as much as possible to ensure that the Basic Care Provision Fund is appropriated for. The rest is history today. We thank him very much for that. So, Your Excellency, that singular act that day led to a revitalization or improvement of like 6,000 facilities that are benefiting from basic care provision for today. Tens of thousands of Nigeria are receiving health that were not receiving before as a result of that political decision. We thank you for that. Your Excellency, you have the floor, sir. Thank you, sir.
Thank you very much. Let me deviate a bit, and I can see a lot of people here are not as tall as I am. Let me adjust that if I can. I deviate a bit because I will recognize a lot of people are here. Let me start with the Deputy Governor of National State. Let me recognize you for being here from the beginning. Let me recognize the Chairman, Senate Committee on Health, who is also the Senator of my constituency. Let me recognize the Commissioner for Finance who are here from Osun, Kaduna, Let me recognize the executive secretaries that are here, distinguished senators that are here, distinguished members of the House of Representatives, key stakeholders, and of course the organizers and those who are joining us virtually. I am very excited to be here. When I saw the invitation a few weeks ago about what Muji was doing, I was very quick to say I will be here because this is a topic that is close to my heart. It is a topic that I believe we all need to get on board and ensure that we can do our best to see how we can be successful on the issue of universal health coverage. I've always worked very closely with Mojima Konjola, so I think maybe it's part of that, also maybe because I'm a doctor as well. But I think it's my experience that I've had on the issue of health sector and how it is so important. Now, I like the slide to show that the population must be healthy for us to be able to drive it forward. And I believe that if we can get this right as a nation, honestly, we'll be doing a lot to put our country in the right place. But I'm a bit disappointed this morning, and I must say that with the attendance. I was hoping that the people that really matter, the political leaders of this country, should be the ones here. Those of you, as I say, are already the converted. Those of you are the technocrats that believe. Those of you are the ones that have been frustrated for many years. You know what to do. You know what is expected. But the real political leaders, the governors that should be here, leaders of political parties, those who are going to drive manifestos and draft policies should be here. Those, and even the DG of the Governors Forum, while I was sitting down there, I had to text him and say, why aren't you here? You know, he said there were a lot of things, because this is important. When I was chairman Governors Forum, the purpose of those kind of is for us to be able to share experiences and come with a common position. Because unless we do that, unless at the subnational level, the governors and at the executive level come together and drive the process, I must commend that the National Assembly are here. But the National Assembly has played their part. The issue now is how do we implement? The tools are there, but what is lacking is a political will to implement. And unless we understand that as political leaders, nothing. 3 more laws, 5 more laws, nothing will happen until the leadership of this country believes in what you believe in, universal healthcare coverage. I ran into, I would say I was a young governor in 2007, and I realized that what everybody wanted us to see was building hospitals, painting hospitals, and cutting ribbons. But the question was that, do those hospitals really impact if we look at mortality, mobility, life expectancy? No, it doesn't. Primary healthcare is where the real work needs to be done. But primary healthcare sometimes does not win elections, in the sense that what I mean is that what wins elections are, when I mean elections, are the attendance, the picture taking, the hard work in the rural areas, where you are taking nurses to the rural areas, you are training health workers. That is the real work that is going to improve our health. But you find that a lot of our political leaders are not interested in that. They're interested in being at the capital, on the major streets, and they have painted a building. But at the end of the day, does that improve the health of our people? The answer is a big no. And that is why I said I was very disappointed. And I think that these kind of conference, and I must commend Dr. Makonjola, we need to get the people that we have. Honorable commissioners, I like you all. You are hardworking. You have been taking notes. But you know what? I'll prefer for your governors to be here, because they are the ones that need to be spoken to. And that is the reality. And until we do that, until we start doing that, we will not get any address or any real issue on primary healthcare. Now, I've had the opportunity as a state level. I remember in 2007 then, everybody was talking about health insurance for the civil servants. And I remember that I said, well, are they the vulnerable? Are they the less privileged? Are they the weak ones? No, it is those in the rural areas who even some of them do not even believe in this type of medical medicine, even to convince them of the importance and that this is where you need to go. In that time, it was 300 naira a year. And it transformed. I have so many stories of people who said, wow, I didn't know. There were people who were walking around with systolic blood pressure as high as 200. They didn't even know because they don't even bother going to go and check. But if you look at what covers under basic healthcare, it's enough for us to bring down our mortality and mobility significantly. Child delivery, death at child will not happen anymore in this country. But the question is, who are we should be talking to? My problem with today is that the people who we should be talking to are not here. And that is the first thing that we really need to sit down. And I think it has to come again, now that we're going to elections. People should be held accountable. All of us here, or all of you, everybody is a voter. Leaders must tell us what is their plan. We cannot continue to be led by people that do not have an idea of what is required to lead this country forward. People must stand up and say, yes, you want to provide better healthcare for me. How do you want to do it? And let us listen to you. But where people can get away without that, there's no way forward. And that is why, honestly, I am happy to see the members of National Assembly here. Because they have done their own role, but they are going the extra to say, okay, what are you doing with it? Because we've passed the law at 1%. 2018 was the last time it was truly funded. Why? Why should it be so? But if the executive arm hasn't got a buy-in, I mean, the minister is not here. If the Senate, the chairman of the Senate can be here, members, House of Representatives, there's no excuse. Because this is what is going to make this country healthier, nothing else. And if it's funding, I'm convinced that we do have the fund. For this COVID alone, I am sure we spent close to 900 billion. If we look at how much we spend as a country. The question as a country today, even if we just take the vulnerable people, or even if we go out to those who are on the poverty line of 80 million, and we can provide those with health coverage, we can fund it. States alone, I'm sure the last budget of the NAS was up close to 600 billion. States probably are spending close to that. Our donors are spending close to $2 billion a year. The money is there. But it's the political will that is not there to drive the process. And until the political will is there, nothing would happen. And the only way it can happen is for us to stand up and hold people accountable. I believe that that is what should be the issue. I like you all. I'm sure you're going to have very good ideas. You're going to speak well, but you're speaking to yourselves. Until you begin to speak to the political leaders, nothing will happen in this country. I'm sorry I'm going to end up on those notes, but that is the truth, that is reality. There are many of us who are going to soon go around the world, go around the country, looking for votes. Pick your leaders. People who want to be governors, ask them what they want to do for health. People that want to be president, ask them what they want to do for health. And people that want to go to, then we know that we are serious. Until then, I don't think so. I leave it at that point. I wish you a fantastic celebration, and I hope we can move this country forward. Thank you so much.
I wanted to pretend I was as tall as the Senate president, but that was impossible. So thank you very much, distinguished His Excellency, for the clarion call for us to do the whole leaders accountable, so that going forward we will not be speaking to ourselves. A number of important points came out of that. But that was exactly why we are here, to start the process of engaging the political leaders, so that, like I said earlier on, we'll be using the power of ideas to influence the ideas of power. So thank you very much, Your Excellency, for that wonderful point. So we also have in the House, I would like to invite His Excellency, the Deputy Governor of Nasarawa State, His Excellency Dr. Emmanuel Akabe, a seasoned ophthalmologist, teachers of ours, universal health coverage enthusiasts. And let me quickly tell you that Nasarawa State is one of very, very few states that have released equity fund as part of their belief in universal health coverage. Your Excellency, over to you, sir.
Thank you. I will like to align myself with the representative of the DG of the Governors Forum to say that our align by the protocol already established. I must commend our dear Auntie Mojima Kanjola for convening this event. I'm here representing His Excellency the Executive Governor of Nasarawa State, Engineer Abdullahi A. Sule. And why I'm here personally was to show how much importance we give to healthcare and to universal health coverage as a whole. I was excited when I listened to other speakers, particularly the chairman of the Senate Committee on Health, on what the National Assembly is doing as at now. And I was quite excited to hear that. Since 1984 till date, I don't know anything else but healthcare. I've been in medical practice all this while. And even as a deputy governor, I still time to go to hospitals to consult because I believe that that is where to go. Quite honestly, like the former Senate President spoke about, and other speakers before me, the way to go is primary health care. We must, as a people, as a government, lay our emphasis on primary health care. Once we get our primary health care rights, everything else will fall into place. Getting the primary health care right is not only, like I said, the structure. We must talk about what happens in those primary health care. We know that over 80% of the voting population are there in the rural areas. When you go campaigning, you're not campaigning to the sick. You should campaign to the healthy. Those are the ones that can come out to vote for you. They can't come from their sick beds. So we must put emphasis on primary health care. For us in Nasarawa State, we take health care very seriously. His Excellency the Governor is quite passionate about it. And as a deputy who is from the healthcare sector, we have our national health insurance law in place. We have the agency in place. We're giving the agency all the support that she needs. And I want to let you know here that we have consistently, and I stand to be quoted, consistently allocated 0.5% of our consolidated revenue into the health insurance. And I was just speaking with the executive secretary and he told me, yeah, last week he got the last tranche of the money released to him. And so far, we also accessed the Basic Healthcare Provision Fund. And we've enrolled a number of our people into the scheme. We just started, but we're moving. At the last count, we have enrolled over 64,000 into the health scheme. This in the informal sector. These are the vulnerables. We are working on the formal sector. We are working with the labor unions, and we've convinced them and they've agreed. And by the timetable, by January, they'll also be enrolled into the health insurance scheme. We've got the support from a few agencies that have assisted in enrolling more vulnerables into the scheme. We need a lot of advocacy. This we're doing, getting the communities involved, getting religious bodies involved, getting the traditional people, the institutions involved. And we're determined that as far as universal health coverage is concerned, it is on the front burner. And our plan, our goal, is to be the leader while the 35 other states follow us. And I'm saying this, and I mean it, because His Excellency the Governor seriously believes in it, and I believe in it. Your Excellency, sir, the commissioners of health are here. They are the chief advisors, the executive governors on health matters. And I'm sure the governors are listening governors. At the end of today, whatever comes out as a communique, they will take them and rightly and adequately advise their chief executives. And as they sit at council meetings, I'm sure they will convince the executive councils to put universal coverage on the front burner in the various states. Unfortunately, I'll have to leave from here. The executive secretary of our health insurance agency is around. He will stay back. I will continue from where I'll leave. I want to thank you very much for this opportunity, and I wish us well.
Thank you very much to Dr. Emmanuel Akabe, the Deputy Governor of Nasarawa State. I think a lot of what he said really resonated, and when he highlighted the importance of primary health care and the communities that we're trying to serve in improving access to quality health care, it's important that in the work we do, we remember that even though we're in the large cities, it's the families, it's the communities in the rural areas that are most in need and are the vulnerable that universal health coverage is trying to reach. So as we continue our program, this first technical session, I'd like to invite Dr. Olumide Okunola, the Senior Health Policy Advisor for the World Bank, to give his presentation on the critical appraisal of Nigeria's health challenges and promising policy options. So Dr. Okunola, if you can come up and give your presentation. Thank you so much.
Unfortunately, I can't see my slides myself. Okay. Hello. Good afternoon. It's a pleasure to be here. Speaking after the political gladiators have excused us. So we're back to speaking to ourselves. And for me, I just want to share in about 5-6 minutes what I will say, what are the policy options that we need to put in front of an aspiring politician, or in fact, a politician who is holding a political office. I believe if we're able to bring all of those kind of points together, then we then make UHC meaningful. Because at the moment, to many people, the concept of UHC seems to be a construct that is from La La Land. Overall, universal health coverage is, we want to expand access to effective health services. We want to increase health expenditures, and we want to rely more on prepaid pooling arrangements. The bottom line of all of that is that you're talking of increased fiscal space for health. But that construct has now increasingly been changed in the last 2 years because you cannot have UHC without bringing into it resilience, where health actors, institutions, and populations are able to maintain their core actions and also maintain good health and learn lessons from that crisis. So we must be able to deliver health systems or UHC-inspired health system within a resilient environment. A health policy maker 3 years ago needs a completely different skill set going forward. Please, if you can just put up my slide, which maybe I would call my most important slide. I can't see it, but if you can, that's fine. Go on, please. So, Nigeria is at a crossroad. We have 3 options. The worst scenario is one where we go back to Nigeria of the 80s. Bad recession, essential health services were cut to bare bone, and we never really got out of it. Another option is where we are today, a lower middle income country, where we can still stay within that space in a business as usual scenario. Or there could be a third way, which is Nigeria rising, where you can then be in the same league of nations like Indonesia. And to be Nigeria rising, which I'm sure if we have a poll now, most of us will want, of course, Nigeria rising. A Nigeria that is economically powerful, a Nigeria where people can actualize themselves. For a Nigeria rising scenario, human capital development is a key part of this conversation. In fact, if you look at several countries in Southeast Asia, almost a third of their economic growth was as a result of improvements in health, reducing mortality, reducing fertility. They were able to move rapidly within their demographic transition and reap a demographic dividend at the end of the day. That is the essence of why we have our politicians here. And this is the kind of argument we need to make, that for us to have this scenario of Nigeria rising, where Nigeria is a powerhouse economically, both on the continent and globally, human capital development, of which health is a key part, needs to be part of this story. So that perhaps is my most important message to you, because if we don't situate health within this narrative, then those governors will probably not listen to us. Next slide, please. So just very quickly, lay the foundation for the interrelationship between lives and livelihoods. I'll lay out my 4 or 5 policy options, which in fact has been more or less discussed. I'm just going to rush through them and end with one slide. So next slide. Of course, it's no news that our population is not apace with the economic growth. What that simply means is that no matter how much we do, when population outpaces economic growth, we will keep racing. And that means there's a challenge in delivering services, providing services. No matter how much work you do, you keep running. So this is our first challenge, right? Next slide. And this also is interrelated or confounded by the fact that our public spending, which, for instance, the Chairman Senate Committee had mentioned, is constrained by the fact that we are simply not making enough money. We're not raising enough revenues. And as been said by Rob, Senator Loregbe, and others, without public financing, you are not able to make the kind of human capital development and accumulation that you require to achieve a Nigeria rising scenario. So that's the second problem. Not enough public financing to take us to where we need to. Next slide, please. But it's not just that we're not raising enough revenues, our situation is particularly bad. Because this is one of the lowest revenue raising or mobilization efforts in the whole wide world. You can't spend what you don't have. So it then simply means if you're not raising enough, you also will not be able to spend. Next slide. And this shows it graphically. Just to humor you a bit, in terms of revenue raising efforts, we're just ahead of Haiti. Next slide. So just to mention that within all of this context, our economy has really been hit by COVID. You know, there's several factors for that. Remittances has dropped, oil prices tanked, people couldn't travel, investments were curtailed. Bottom line, livelihoods were affected. Next slide. You're very familiar with it. Lives were lost. So overall, it's clear to all and sundry now that whatever happens within the sector has a knock-on effect on the economy. Next slide. But overall, from the macro situation, the bottom line is reduced public financing, inability to raise revenues. Bottom line is you have very poor human capital development and accumulation. And I think Anu shared the statistics earlier on, what Nigeria and where Nigeria is on the Human Capital Development Index. Bottom line, I'll summarize again what Anu said. A child born today, given the level of education, health, and skills available to her today in Nigeria, would only be able to achieve 36% of our potential by the time she's 18. Some other countries are in the high 80s, like Canada, Hong Kong, Singapore.
But several African countries are also in the mid brackets too. For a country, and I go back to my first slide, for a country that wants to be Nigeria rising, you got to do better with your human capital development efforts. So, I think we set the stage. What am I then proffering as policy options? Next slide, please. First is that UHC, as I said, you're expanding services, you're increasing health expenditures, you are relying on prepaid pooling arrangements and all. It means you need to spend money. When a recession hits, like it did during COVID, like it will happen and continue to happen for some time to come, usually what you do in a recession, people in finance and Minister of Budget will say, cut costs across board, which is a pro-cyclical approach to stuff. The first thing you got to do, because of the things I've said earlier on, because of the intertwinedness and interrelationship of health and the economy, in fact, that's when you increase spending in the health sector. We need to establish that first. You got to go into a counter-cyclical mode. If you don't buy vaccines, if you don't expand testing, for instance, now, there's no way the economy is going to come back. So let's establish that first. And I think if I do a poll here, everybody will say, look, that's the way to go. Not just here, I wouldn't do that poll here, in Ministry of Finance, because they know. The good news is that this is a policy approach that I think has already been adopted by the government of Nigeria. This is a slide showing what happened last year. This was what was originally budgeted, and this is what was revised when COVID hit. Nobody needed to make any special case to the Minister of Finance, Budget and National Planning. Nobody needed to go to the National Assembly. In fact, all the Minister of Health or health leaders needed to say was, we need 1 billion. We need to take, and I'm sure that also happened at the state level too. But it's not a one-shot approach. This is the time to maintain such level of spend and such approach to spending. Next slide. The second thing that we've seen from COVID and even before COVID is that the number of Nigerians falling into poverty is on the rise. COVID added a lot more poor people into the pool. And that's our reality. And one of the things Sikabe said before he left is, in a situation of fiscal constraints, then you need to prioritize the poorest and vulnerable in your society. Okay, I don't have much, but at least this little I have, let's first protect these ones. And I'm glad to note what the Deputy Governor of Nasarawa mentioned in terms of we are providing as mandated for our equity fund for our state health insurance scheme. But our levels of ambition needs to go beyond what it is currently, because, and this is something that should not necessarily sit within the health sector. The poor man who is benefiting from either an agricultural subsidy or some other kind of subsidy, can't we just be able to better identify this person and provide this person with a bouquet of services? And I think this is a conversation that we usually approach mostly from the health perspective, as other sectors are approaching it from their own perspective. But this is the one where a whole of government thinking needs to come into play. Let's identify the poor in our state, and let's say this is the bouquet of services that is available for this household. All of this will come together in my last slide. Next policy option, please. This talks about an explicit benefit package. And what this simply means is this.
This will happen, whether we like it or not, at some point, but a smart politician, a smart health leader would say, Mr. Governor, Madam Minister, if you have 100 billion to give me, I will deliver a package that is worth 12,000 naira to X number of people. The sector, on one hand, needs to get to that level of accountability. There's a health sector black hole. Right now, we're pumping money into the basket. A savvy health leader can say, okay, we can use this for health resources, use this for labs, use this for that. But perhaps there's an easier way where we say, this pool of funds, let's negotiate at the beginning of the year. Give me X and I will guarantee Y number of people this package of services. A point example today. The Federal Ministry of Health gives 55 teaching hospitals billions of naira. The same amount of money, we can sit down. This naira money I'm giving you, let's divide it per capita and give it to you, and you deliver those services. If this conversation does not get to one where we would define a benefit package, Section 3.3 of the National Health Act is clear. All Nigerians are entitled to a basic minimum package of health services. Modicare, you can Google Modicare. Modicare is not giving Indians, the poor Indian, basic package. Modicare is guaranteeing Indians access to catastrophic services. That's really where we should be, but that's a different discussion. First point for me, let's define what that package is and negotiate with my governor, with my president. This package, if you give me X, I will cover X number of poor people. If it's only the poor people that we can cover. I think it's just important we emphasize that. And the sector needs to be ready to be accountable, to say, let me be accountable for what you give me. Next slide. So, then the governor asks you, or the president asks you, so where will the money come from? You know we don't have money. We are not able to raise enough taxes. There are two parts to that discussion. The overall tax reform process, which I'm not qualified to talk about, but the one I can talk about is taken from what Rob said, what Mrs. Hillary Clinton said the other day. We got to make use of this crisis. This is the time for the health sector for us to come together as one and push for pro-health taxes. In this regard, I'm talking of taxes on alcohol, on tobacco, on sugar-sweetened beverages. For alcohol and tobacco, we are one of the lowest countries that tax those products. For sugar-sweetened beverages, we are not even taxing at all. But the good news is the Minister of Finance a few weeks ago announced that through the finance bill, they're going to introduce the taxes on carbonated drinks. But we're not just saying introduce these taxes. We are saying introduce these taxes because it is the sector that will bear the brunt in 10 years' time, either through cancer or through obesity or through increasing prevalence of non-communicable diseases. So our ask is dual. First, because right now those taxes are too low, raise them, but please earmark them for the health sector. And by the way, on the health side, the numbers are rising. This is just to show you the kind of numbers that is coming out on soft drinks consumption. Next slide. Actually, if we expand the definition of pro-health taxes, it's not just those health damaging products, but you also include fossil fuel, petrol.
Just a quick calculation is Nigeria is, in this coming year, we spend about 13,000 naira per person on subsidy, fuel subsidy, whilst we're spending 3,000 naira on healthcare. Next slide. So I think we need to also get involved in that conversation around, okay, when you remove these inefficient subsidies, the areas where they need to be pushed to includes health, education, social protection. And this is just showing the kind of numbers, and these numbers are not small. Just using from a low base scenario. Next slide. My last policy option talks about, look, this sector is very inefficient. And there are many things we can say about inefficiencies. An example is pharmaceuticals. And I'm not necessarily seeing any major reform in that space. I mean, you still go into hospitals, people are still writing branded prescriptions in Nigeria. I mean, that's just one of the many things. You know, we can go all and all into that, but this is one area, not just pharmaceuticals. There are other areas of inefficiencies that we can talk about, but pharmaceuticals consider a big bulk that needs to be unpacked. So my case is simple. We want to increase financing in health. We want to recognize and target the people that will benefit from that increased spend. We want to give those people a defined benefits package. In other words, just what I've described, and I've also told you where the money can come from. This is, if you go to the next slide, this is just me thinking aloud. Let's assume that we were successful with the earmark taxes from sin taxes. And let's assume we get maybe 1 trillion. You sit down with the Minister of Finance. 1 billion or 1 trillion can define a benefit package costing 12,000. NHIS uses 12,000 naira, or even 15,000 naira, or even 30,000 naira. But it can deliver for X number of people. And states can say, in fact, if you give me this, I can also cover for an additional number of people. We can route it through BHCPF. I'm hearing today now that NHIS wants to set up another vulnerable fund. I'm not sure why that will be necessary, but either way, let's consolidate rather than fragment and approach this in a holistic manner. But I think the system needs to be ready to be accountable. We need to be ready to make our case in a much more nuanced manner to say, for the amount of money you give me, I will deliver X number of people. Thank you very much.
Thank you very much, Dr. Kunala, as always, for your speech and explaining how, as a country, we can achieve our Nigeria Rising and all the policy options that are open to us. I think many of them we've heard before, and we really need to get those key political leaders in the room to hear and understand some of these. I think most of you are probably very low on sugar, as we said before. So can we take this opportunity to have a very brief 10-minute break, and then we can now go into the first panel session. I know we're running a bit late, so if we can keep it to those 10 minutes. I know that's very brief, but we'd really like to get you out of here as early as we can. Okay, in terms of the tea break for representatives of governors, etc., we've made provision for you to have your tea break in a room upstairs. So everybody else, we'd like to welcome you to come to the forum and have your tea break, and then we can come back here and convene and start the first panel session. Thank you very much. So if we can convene here by 1:15 at the very latest, that would be great. Thank you. session is looking at articulating a health agenda and obtaining commitments for enhanced prioritization of health. So I'd like to also welcome some of the other panelists who will be on this session. And also Dr. Usman Guarzo from Lafia Project. Sorry, Njide Indili is the country director for Climax Health Foundation, and Dr. Usman Guarzo is here on behalf of the Lafia program. Okay, so representing the governor for Ekiti State, I'd like to welcome Dr. Oyebanji Filani, the Honorable Commissioner for Health and Human Services of Ekiti State. You're welcome. I'd like to also welcome Chief Muji Makanjola, who is the founder and head of ISMPH. Welcome, Auntie Muji. That's fine. Governor, representing. Yes, yes, okay. I'd like to also invite Dr. Ben Nkechika, who is representing His Excellency Dr. Ifeanyi Okowa from Delta State, to join us on the stage for this first panel session. And also the representative of the governor for Osun State. Thanks. No, I don't. I lost the paper. I need the paper before. And I'd also like to welcome the representative who's here on behalf of His Excellency, the Senate President of the 8th Assembly, Dr. Bukola Saraki. Madam Fati, to come on and take the stage. Okay, so given that we have overrun a bit on timing, you will see that we have about an hour scheduled for this, but we will invite the moderators to have this discussion for at least the next 30 minutes. That way we can also get through the other two panel sessions and give all our distinguished panelists enough time to discuss this. Thank you.
Thank you so much, Vivian. Again, good afternoon all. Good afternoon to all the panelists. And I know that time is fast spent, so I hope we still have the energy to listen. Universal health coverage across the world is on the front burner. And something which we know is very critical is the political will. And His Excellency, Senator Saraki said it all. In fact, after he's finished speaking, I wondered if there was going to be this session, the panel session, to discuss some of the ideas, because really, in putting this panel together, the idea was, how do we get the commitment from the political class, especially the governors, especially those that are going to put together their manifesto for 2023. But that notwithstanding, I think we have able representatives here who I know most are in direct conversations with their constituencies, with their governors, And without any particular order, I want to start with Dr. Oyebanji Filani, who is sitting by my right, representing His Excellency Dr. Fayemi, who is the chairman of the Governors Forum. So, Dr. Banji, I know that Ekiti State has been doing a lot. We also see the political will of Dr. Fayemi. Can you really, maybe in 3-4 minutes, tell us about how he prioritizes healthcare investment, given limited resources? I'm sure he's been pulled in different directions. And how do we ensure that UHC is achieved, at least within Ekiti states, now that we're going state by state in terms of decentralizing health insurance?
Thank you very much. First and foremost, let me apologize on behalf of my boss, who really wanted to be here. Sunday evening, we still sat down together debating how he should put together his points, an indication that he was really interested in being here, but unfortunately, other events then came up, which made him unavoidably absent. Two things stand out from his personality, right? And I'm glad that you mentioned the political will that we have in Ekiti State. The first is that if you look at his history, he's a development person. So he's always worked in the development space and he understands very clearly how this works. The second is his PhD was on war studies, right? And for someone who studied war, he understands that you have to be healthy before you can even fight, right? So if you take those two, you begin to recognize that this is someone who has an idea of the linkage between health and human capital development. And to prioritize health then becomes of second nature to him. Last year, actually this year, I realized that, because I joined his administration in September last year, this year we had tripled our budget, our capital budget for health in the state. And for the first 2-3 months when this happened, I kept asking myself, I hope it's not because of me that this was done, right? But then I realized that this is who he is. In his first administration, 2010, 2014, he committed very heavily investing into health, and we're seeing the same now. There are obviously, it's a small state, our resources are limited. There's so many things that we need to do. But recognizing that if people are healthy, they can become productive. If they are productive, they can, they contribute to the GDP of the state economy. And as we expand our tax base and even the net, we know that the more people are healthy and they can work, then we can also get some money back from taxes to further supplement some of the work that government is doing. So this is very clear to him, and this is something that he holds there. And based on that, it's not so much of a challenge from the East perspective or from the state's perspective for us to ensure that we invest heavily in health, invest in our people to make sure that they are healthy and that things can go right.
See, that's quite commendable. And before I hand over to Dr. Bazo to continue with some of the panelists, I wanted to ask just since you've been implementing health insurance, how many people currently are covered? And can you give an estimate of, or even a projection or commitment as to when you can potentially achieve UHC within Ekiti State?
Okay, so at the moment we've covered over 120,000 people, but I try to distinguish between, let me say enrolled, right? I try to distinguish between those who have been enrolled and those who actively utilize the service. And I think that's the metric we should be focusing on. We can enroll 500,000, 2 million persons in one swoop, right? It doesn't really mean anything if we don't have people utilizing the service, which means that they know about the services to be utilized. They know the facilities to go to. The facilities are functioning optimally, and we have the data, to be able to see how this works. So all this we've put down as a state. I think I was speaking to Yusuf just earlier on, and I mentioned to him that Q1 next year that we'll be inviting quite a number of people to the state. This is one thing that we hope to be able to showcase as a state. Say this is what we've done. Yes, we know the numbers we've enrolled, but this is the way we're going. At the click of a button online, you can literally see those who have utilized services, what services they've utilized, what facilities they went to. And if you want to call them just to be sure, we have that sort of data available as well. Our goal as a state, recognizing again, like I mentioned, that it's our fiscal space is limited, is to continue to explore multiple options to mobilize resources into this pool, part of which is, of course, some of the resources that come from the federal to the BHCPF, some of the funds that we are actively engaging through our partners to pull through, but also philanthropy. We're exploring opportunities in the philanthropic space to expand the services. One thing that is important to note is, and I think Olumide tried to touch on this, is what your package looks like. An essential package is critical. Common things occur commonly. We don't need to put the fancy things to start with. 70% of the disease burden in Nigeria can really be treated at the primary care facilities. So if you have that essential package that doesn't cover one too many things, it becomes easier to provide that package for far many more people if you look at the cube, rather than have an expanded package for a limited number of persons. And that's the approach that we're taking in the state. Thank you.
Dr. Gwazi.
Thank you very much. We are glad how some governors are making a lot of effort. So my question goes to the representative of His Excellency Ifeanyi Okowa. And my question goes this way. We know that your governor is trying to do much in health. So can you just tell us what hinders that in your state?
Thank you so much. When my principal was recently came in 2018, he set up a committee that will holistically look into health and how we can improve health in our state. I was part of the previous administration as the commissioner for health then, so I was part of that committee. And basically, what we recommended was that we should invest heavily in private care. As such, when the administration came on board fully, we set out at revitalizing. I would say revitalize because not only renovating, we revitalized 332 health centers in our state. We have 332 political wards, meaning that one health center per ward was revitalized. We equally sank motorized boreholes, provided drugs and then basic equipment. But basically, what do our people need? We want our people to go to our center to have their blood pressure monitored, to have their glucose checked, and all that. So we provided all that into our health centers. And going forward again, the issue of health insurance in the country, at the risk of being immodest, I think we rank among the best in Nigeria. We didn't start it, but when our health insurance was when it commenced, and at this point in time, I would like to appreciate Dr. Gavan Alaude, the previous health finance and governance and AP Plus. They actually did well, in midwifing and attending to delivery of health insurance in our state. We are really doing well. We have covered over close to 500,000 people in my state, vulnerables, and Mr. Governor actually paid 477 million naira as premium for the vulnerables. We taxed the political office holders in their respective constituencies for them to pay for vulnerables. We did all that when the Basic Healthcare Provision Fund started. We were part of the 3 states, excuse me, that commenced ourselves, Niger State and Abia. Even at the time, no fund had been paid. We just suggested to governor that we needed to test run how the basic care provision fund will look like, and we selected one local government per each. We have 9 federal constituencies, so we selected 10 local governments in general, and we selected 33 PACs and local government for us to test run the implementation of basic care provision fund. We did all this basically because we knew that majority of our people live in the rural area, and we need to take health to them, regardless of where you live, regardless of financial status. You must have access to health, qualitative health, because health is a human right. That's pretty much what we have done in our state.
So just a follow-on question. How do you manage competing priorities You have a focus in health, you want to address ABC, but a lot of competing. I'm sure when you go to executive council meeting, you try to explain to bring health on the front.
My governor, he was part of the previous administration. He was the chief of staff then. And like I did mention earlier on, I was part of the previous administration too, as commissioner for health. He knew the areas where we had problems. And as soon as he came on board, he really wanted to address those areas. Even before, like I said, before the cabinet was constituted, we've had problems in retaining consultants, in our state. We employ consultants, after 1 or 2 months, they leave because they could get better pay in other states. And that was down to our inability to pay the revised comments and conheads. So as soon as Mr. Akono came on board, look, I want to pay these revised comments and conheads because I want us to retain our doctors. We did that. He paid all that. Simply because he was an insider. He knew the problems we had previously, and he wanted to put a stop to that. So it became quite easy for us to, at the risk of competing things for government to do, we really made health as the flagship of our administration, and it wasn't that difficult at all.
Thank you very much. Over to you.
So, not that I'm skipping the ladies, but I want to get the experiences of the state first. Then we can then go to, the foundation around it, as well as, the UHC perspective and how we're going to bring this all together. So having said that, I want to go to Dr. Ben, because Dr. Ben is representing His Excellency, Dr. Kowa, who has been a champion for the healthcare sector. And some of you may not know, but I happen to know that Delta State is the state that has enrolled by far over 1 million lives. And I want to ask you, Dr. Ben, how is it possible that what political structures did you put in place, or what best practices have you put in place? Should it be because the governor the governor is a doctor, or what exactly? Because I think these kind of forums, we should be sharing best practice so that other states can learn and adopt and adapt. But really, what are you doing differently that you're so successful in terms of pushing UHC?
Thank you very much. I'm here to represent Senator Dr. Ifeanyi Okowa, who has a busy schedule or a significant engagement in Delta State. For our level in Delta State, it was purely a case of a deliberate political will backed by policy that is actionable and with landmarks that we have to achieve. So first of all was the fact that we had a strategic implementation plan for the health insurance program, which spanned 8 years, starting with a startup phase, a sustainability phase, a consolidation phase, and a continuity phase. Our continuity phase starts 1st of January 2022 and is designed to ensure that all the steps we've taken remain formidable and continue beyond his administration. But coming to our startup plan, it's interesting to note that the governor was a chairman of the past Senate Committee on Health, which came up mostly with the National Health Act. And so he had a deliberate plan to ensure that there was an implementation at a state level. And while he was consulting to be a governor, I followed him to every consultation meeting. While he was campaigning, I followed him to every campaign ground, taking notes on how to develop a health financing policy for his administration. As soon as he got the position of a governor-elect, he set up a team. When the transition committee was on, he actually set up a team called the Governor's Team on Health Insurance. So before he was sworn in as governor, the bill establishing the Delta State Contributory Health Scheme was actually ready. And if you check his inaugural speech, he said within 3 months, the bill would be at the House of Assembly, and it was there. And he insisted, I sat in every House of Assembly session where they debated the bill. And when the bill was ready and they took it to him, he insisted I was there when it was signed. I handed it over to me and said, make sure you implement it. And that is what I call a deliberately focused political will. Not just that, I gave him a briefing on the progress of the health insurance scheme every morning at 8:45 a.m. Every day I had to do that until he was comfortable enough to say, okay, send your reports. He's provided us with everything we needed to do. And at every situation where there were challenges in terms of supply side, demand side, he called a meeting, everybody sat down there, and he deliberated and got it done. So it has to be deliberate. We should stop looking at just political will. Political will is just an interest, but when it's deliberate with actions, then you can have the kind of outcomes we've seen so far.
I think that's very useful information. I've just been advised to tell all the panelists that when you're speaking, you should remove your mask so we can see your face, but more so because the recording, your voices are not coming through. So hopefully, Omicron, is that what they call it? It's not in this room, right? So, Dr. Ben, I think that is really excellent. I happen to work quite closely with you, and I know that a lot has to do with leadership. The person that is driving the agenda, both the political will or the processes that have been put in place. And I know for one that Dr. Ben himself is very passionate, much like, you know, some of the people I have also interacted with, states that are making progress. It starts at the very top, backed by political will, but follow through in terms of action, following a strategic plan. So I think it's a very good point that you made there. And I'm hoping, you know, those taking notes, somehow we're going to put together. But also, Dr. Ben, you are advising, I think there's also other channels where you can share some of what you're doing. Is that right?
Yes, we try to, as much as possible, advocate to other states. We have a partnership with UNICEF right now, where other states are brought to Delta states to understudy what we do. And we also go to other states to actually share experiences with them. My friend here, Gaza, is he's a years of the health insurance scheme in Nasarawa State, and we have a lot of interactions. But what is most important is the fact that we need to start looking at health insurance from a country perspective, a national perspective, instead of state and federal. And that is what seems to be situating with the Basic Healthcare Provision Fund, where it's a federal, the state. But when we look at it from a national position, like I was speaking to my colleagues, I said, we should start looking at a health insurance exchange in this country, where if somebody enrolled in Delta State goes to Nasarawa State to receive healthcare, at the end of the day, we can have an exchange to reconcile the bill and pay. If any of my enrollees travel to Sokoto or somebody comes to Delta State, that is what we should be looking at. And the Basic Healthcare Provision Fund has now created a baseline benefit package, which can become a standard for everybody to implement. So yes, we have this fora, but we believe that where there's that collaborative interaction, things will get better.
To Dr. Gwazo, I wanted to pick up on one last point that you made, which is in-country resource mobilization. I know that there are quite a number of donors, there are quite a number of partners, developmental partners, including myself, by the way, climax, through the Dutch government. But I also know that the amount of funding coming in for healthcare is shrinking. In fact, what they want to see is leadership from not just the state, but the federal government, then they can support those activities. So I think it's something else that needs to be noted, that our political class needs to take ownership. When they do take ownership, and show a clear strategy, accountability process, you will find the money flowing to support you. So I wanted to put that on the table before I hand over to Dr. Kwazo. That it's really important.
Let me quickly say something. Yeah. It shouldn't just be that the resources should be domiciled in the state. Every health insurance program should be self-sustaining. In Delta State, we consider the government as a payer. We don't run. So the government pays for premium of its people, and that's where it ends. We don't depend on government. So if the governor, if we don't receive funds of the civil servants, we'll write to the governor that in 1 month, 2 months time, if you don't pay, we won't provide service to them. And once that is done, everybody understands that you need to contribute. So there should be that self-sustaining mechanism where the government knows that for you to benefit, you must pay your premium. The individual knows that for him to benefit, you must pay your premium. That's what guarantees the funding into the system. Thank you. Thank you very much. I'm going to take like 2 questions, and the second one will come as cross-cutting so that we share more lessons from anybody willing to contribute. But the first one, the representative of his distinguished Senator, Bukola Saraki. We know the history from 2017, 2018 on the appropriation of USC. So what can we learn from what motivate your principal to prioritize and ensure that appropriation?
Thank you very much. Motivation came from the success recorded by the implementation of the community-based health insurance scheme in Kwara in 2007. This program won the Financial Times Award in 2016 for sustainable achievement in sustainable development, maternal health, and infant health. So there was no doubt that it would work. This program ensured that people had access to equitable, accessible, affordable, and quality healthcare services. There was no doubt that it was going to work once it was pushed further out.
So, from your own opinion, how do you think will influence political gladiators to prioritize universal health coverage in 2023? When you contribute, I think everyone also need to highlight or follow the queue. Thank you.
I think advocacy goes a long way. We need to be able to have people understand the linkages between health and economic development. Once you have a healthy community, then you're going to actually have a chance of having economic prosperity within that community. People kind of understand the linkage between investment in health and investment in infrastructure. So they see the hardware, but they don't actually prioritize the software that is actually involved in this system also, which is what? Human capital development, and having systems in place that are actually going to help strengthen what you've built on with the human investment in human capital development. You can build fantastic hospitals, fill them with the best equipment, but that doesn't mean you're going to deliver the kind of healthcare services that your community needs. So you must invest in this awareness for both the legislators, the politicians, and then the general public themselves. People have to understand that today, one bout of malaria is not just one bout of malaria. That can send an entire family into cyclical poverty. You must have awareness of these kind of issues that are raised, that come up of this kind of thing. Periodic engagements is very important. Support and participation in fora such as this one will help in a long way in that kind of awareness and education, especially to the politicians. It is important to engage with them on a regular basis on this kind of level, so that you are actually spreading this kind of information and it reaches the grassroots. Because your politician is there because he's voted into office. He's a representative of his people. If his people understand the need for this kind of thing, they will hold him responsible and accountable for delivering on these kind of promises. And it's very important also, promises are made, are promises kept. We must ensure that. So like I said, engagement and awareness, constant engagement, not just once every 3 years. It has to be periodic.
Thank you very much. One key point she mentioned is the issue of engagement. And that leading me to take the question to Auntie Makanjana. What do you see the role of bottom-up approach in engaging politicians?
Thank you very much for that question. Bottom-up, very important going forward. What have we achieved with bottom-up? If we look at the success story of the health sector in Nigeria, it has been engagement bottom-up. We're sitting here in this hall, hopefully, with the media, getting it across to people, but it's served as one meal. and you eat it and it's gone. But if you start from the very bottom, getting the food at all, then getting it ready, cooked and served, then it will stay on. So I'm an advocate of bottom-up approach to issues, particularly issues of health. As a COP reporter, starting with late Health Minister Ransom Kuti, he didn't sit in Lagos then to ensure the success of immunization for all. He went to the ward level. And that for me resonates in whatever I do. In our messages, in our writings, in things, in our interaction, in our engagement, we must start looking at the people considerably. A lot of them live at that level. And until, of course, we get them to buy into things that will improve healthcare delivery in Nigeria, we are just talking to ourselves. And for a lot of us who are here today, who are program implementers across board, we found out that issues of getting people at the grassroots involved has been the success story that we have. But a lot of misunderstanding does happen when we do not carry them along. Mistrust, which is the major issue that we have today. People don't even trust what we are doing. So when you get them, when you dare to invite them, it is, they're talking to themselves, Joe. You know, it is treated with such levity. And that's where we lose the seriousness that, you know, should come with it. So for me, starting bottom up is important, but getting policies there. And I always advocate that we should please start thinking of using our local languages. What's wrong with our local languages? I've traveled around the world a bit, and I was in India at 1 year, and the success of they being able to manage and reduce maternal mortality was because they spoke in languages, and they galvanized the women and the men and everybody because they spoke their language. So trust was established. So much so that the women came together and built a hospital for women, by women, manned by women. And for me, that's a huge success story. It started from a mud house and became a big hospital in big cities. So I would strongly, hopefully, that in our community going forward today, we must ensure that starting from the grassroots is important. And I'm sure that when His Royal Highness speaks to us at some point, we'll be able to see the success, the Shonga experience is there for us to see, to know that health for all, universal health coverage using the health insurance can work even at that level.
Thank you very much. Jide, over to you.
Thank you, Dr. Gwaza, and thank you, Muji. I think what you said is spot on, and we're going to hear from His Royal Highness, the Emir of Shonga, what he actually did to communicate with the grassroots, you know, the Friday prayers, and how he was able to galvanize the Shonga community to even enroll. But I forgot that we had Rob Yates online. I didn't realize you were still there because we're running behind schedule. And hopefully you've been following the conversation. So before you add some comments, I wanted to ask, because you made a fantastic presentation this morning in terms of how you support the political process, countries. What advice would you give our political class, our political leaders, governors? What can we do differently? Because we've been at this for so long, but the needle is just moving so slowly. What can we do to really get the ball rolling? Your advice?
Well, I would say, and this is the encouraging thing about health, is that you can completely revolutionize your health system surprisingly quickly. I know that we know that health sectors are very complicated and there are lots of different systems, but I personally very much got switched on to this whole issue of engaging politicians when I was based in the Ministry of Health in Uganda in 2001. And we were doing very slow reforms, just like you're describing. But 10 days before the presidential election, President Museveni scrapped all healthcare user fees through the entire health system from the big hospitals right down to the primary care level. And we in the Ministry of Health knew nothing about this. You know, it just came out of bolt out of the blue to us. And I must admit, we thought that the president had gone crazy. But he did two very smart things at the same time. He increased all the health workers' salaries and instructed finance to do that. And he also enabled us to buy lots and lots of medicines. Obviously, we didn't have time to build lots of health facilities in that time. But just doing those two things very well, we saw a doubling in the utilization of health services, with it primarily benefiting the poor. And in effect, what he was doing was using tax financing to provide this universal free healthcare. So you can do that remarkably quickly, and people might find that astonishing. But even in Nigeria, you'll be aware that there have been some states, like Ondo State, where Governor Segun Mimiko introduced universal free healthcare for pregnant women and children. Very successful, very popular, and had a big dramatic impact on maternal health services. So the message is that you can do a lot with health surprisingly quickly. And it was our experiences in the UK at the end of the Second World War. At the beginning of 1948, the health secretary didn't have a single doctor registered, and it just seemed like a complete fantasy to talk about launching an NHS in July. But he did it, and it was, you know, one of the greatest successes, political successes, ever seen. So I would very much say that these are the messages we need to be relaying to our politicians, that if they're really serious about this and they put the resources in, you can do amazingly dramatic things with your health sector to create that demand surge. And so long as you put the money in to pay health workers' salaries, to provide medicines, that even with limited infrastructure, you can have a dramatic impact on people's utilization of services. So I would say that at Nigeria's income level, you could do that perfectly feasibly in 6 months or a year if you were serious. And those are the messages, I think, very much when you're having the conversation with the politicians, to say, just imagine the political benefits that could bring to you in being the hero that brings healthcare to the masses. I'm convinced it is going to happen in Nigeria in the next few years. I don't know whether it'll be 1, 2, 5, 10 years. Someone is going to do this in Nigeria, and it's very much to encourage the politicians. You know, it could be you. You could become the UHC hero in Nigeria.
I've been friend to Nigeria and a partner to my program Lafia. So I just want to Rob to give us some roadmap of how they think they will provide the needed support and contribution to Nigeria as we are prepared for 2023. Rob, over to you.
Sure. Thank you very much indeed, Dr. Kwaza. And I mean, I think you've got a wonderful opportunity now. Everyone's talking about political windows of opportunity on UHC. That we hosted a UHC summit, not dissimilar to this, but in South Asia on Tuesday with UNICEF. We had health ministers from all over South Asia participating. And you had countries that have made the big leap, Bhutan, Maldives, Thailand. They'd all done exactly the same thing. Sri Lanka as well, another one. And then there are countries that were struggling with about a 1% GDP per capita health spend, big populations, federal structures. You'll recognize this. You know, so it was Bangladesh, it was Pakistan, it was India. But you can see there were political actors thinking, we can make that transition. Now, what we hope to bring is this sort of expertise and knowledge about the countries that have made dramatic interventions towards UHC. It's fascinating to look over history to see these transitions don't happen slowly. They happen in big bang ways, and they happen during or after crises. So with us being in the midst of a crisis at the moment, with you having elections coming up, it's just the obvious time for a smart politician to think now is going to be the chance. You can see that there are Democrats in the United States thinking the same thing. we don't know whether Joe Biden's going to run a second term, but certainly some of the people who are thinking of taking over the crown there are thinking along those lines. In Kenya, there are county governors who are looking to run in the presidential elections coming up in a year or two on a UHC platform. What we would aim to do is to provide that type of strategic advice to actors, political actors in Nigeria, give them the best technical assistance about what works, what doesn't work. I'm afraid there might be some sort of, home truths here about the potential for contributory insurance to get you to UHC quickly. All the evidence, and WHO and the World Bank, everyone's saying it now, really what you need is to tax finance the informal sector. And in effect, do what President Museveni did. Scrap healthcare user fees, provide free services for the masses, but you can take social health insurance contributions from the formal sector as well. We are so well connected to all these different countries doing this. We'd be delighted to bring that expertise into the situation in Nigeria. We can host roundtables, we can participate in summits, but a lot of this type of stuff, because it is politically sensitive, might be best done on a one-to-one basis sometimes, or in small closed groups. But we are fully available for this. Obviously, Nigeria, the biggest country in Africa, could have a phenomenal impact, not only on its own population, but the rest of the continent. And if we can be part of this catalyst that really kickstarts UHC reforms in Nigeria, going into and through the next elections, it would be an absolute privilege. So we're ready to come. I should emphasize that we don't have core funding for these activities, so we will require funding for this, maybe from the likes of LAFIA and the FCDO, or maybe the World Bank. We know that the World Bank are very strong on UHC now. So we are available, but we'd need funding to do this. So it's a blatant pitch for us to have support to come out and join you. And Aliko and myself would be only too happy to come out in the new year to start that process.
Engineer, over to you.
Okay, so before we round up the panel, I wanted to, I don't know if we have a mic, so we can have His Royal Highness just give us some nuggets of advice on how to handle the political class.
Well, thank you very much for this opportunity. Thank the organizers for this opportunity, all distinguished guests here. Yes, the political class are very interesting. Somehow they just feel as part of ingredient of getting to the top. They come, they meet you, they're quite humble when they meet you in the palace. They discuss, they want to canvass for votes. Then sometimes they bring certain projects. But if they bring the projects and all that, once they're gone and the people come back and ask you, what's the project? And you don't know enough, it's dead on arrival. Okay, but what they do is promise, you hold on and say, look, if you want a second term, if you're coming back, I'll keep asking you about what you promised. Some do work. In fact, I remember when I was a chairman of HAFON, Health Reform Foundation, we did advocacy visits to governors. And we said, we have found something very interesting. If you can pay attention to health, primary health care, make sure you go to every nook and cranny, local governments, and also take along with the education. There may be a few things like agriculture, and spare the big infrastructure for now. You will get a second term. And we've then ruled out certain statistics of certain governments that did just that. Because you want to reach every person, you want everybody's vote. So one thing to just tie to that was this. Now, coming back to the insurance we had in my community, it was quite splendid. It was also initially startling. But I found that even a doctor within his community with all his influence has to really work hard on attitudes. Like the rest of Nigeria, actually. Like I always say, wait, by the time we finish all the meetings, I always say what resonates all through our meetings, attitude. If we can change attitude, many things will work. Now, what happened here is that you then come first year, oh, they're excited, like just all these stages in a new change. By second year, they are prepared to contribute again. And by third year, they say all sorts of things. I've not used it over the last 2 years. Okay, can you transfer my money to my brother? Can you also say, So then we start preaching the spirit of solidarity. We start, in fact, talking about arms, sadaka, and so on and so forth. Then half get convinced, others just drop out. So it means that the factors contribute to getting yourself reinsured can be quite deep and profound. And so you must not take it lightly. Keep a tab on what's going on. Every dropout must be fully interviewed and discussed with, and then we can use quiet influence, not the stick, but quiet influence to get things to work. I also wanted to just mention very briefly the issue that the director talked about. Actually, I was asked to chair 1999, 1998, a forum on health insurance. We just trying to bring it back in, and Liberty was running it. So they wanted to get vulnerables into the national grid. And so OBJ, Obasanjo, the president, said we should form a committee. So they made me chairman of the commissioners committee. That was very odd, but okay. So then we sat down and really worked out very carefully. We talked about beggars coming from Lagos to Kano and then coming back again. How do you capture them? We had a national ID. And so we listed all that. In addition, we listed how to get national ID and so on and so forth. The figure was so humongous, we got only one word back from OBJ, no. But then 4 years later, he scrambled back and then started the insurance. So to me, that was quite great. He thought through it, he knew where to put things. So there are a few more things I can talk about. Maybe there's time we can talk about here, but I think time is well spent. So our experience was quite accelerating. The last word I said about advocacy to traditional institutions is that you can have a multiplier effect with them. They are supporters of your government. In fact, the first thing we tell ourselves is that you are loyal to the government in power. You're a public servant. You have no political views. You can make corrections through the right channels or personal contact with the government to correct a few things you think are wrong. But you give solid support. And so also with programs, you give solid support. And you can rally your people easily, you have a multiplier effect. I'll stop it here unless you have a specific question. All right. So sorry, I'll just conclude that part about the vulnerables. So the conclusion was that whatever you set up, you should have a beggar travel, let's say the beggar as a prototype vulnerable. You should be able to have him travel from Lagos, go to Kano, where probably he belongs, or Maiduguri, and capture him again, and have a common way of, like the banks do, of trying to, while there, use his card, and in a manner that you equilibrate and finally level out the monies. But if you have a national situation like he was describing, with those one recommendations we made there, who was secretary? Mimiko.
Just a follow on, when His Royal Highness was talking about the issue of recruiting these vulnerables, he made mention of arms, he made mention of Dangote, and I think recently what we started seeing is how important it is for us to look at alternative financing in trying to support this group. And we in Lafayette have started making some preparation to come up with a roadmap of how we can use alternative financing in supporting universal health coverage. I don't know whether His Royal Highness will share some of his experience in relation to that. What are the things which we need to be cautious of? Yeah.
Well, I don't know which one you're referring to, but at least if you're properly organized and very accountable, people are prepared to donate to you, particularly external donors. Yes, you say don't be too dependent on external donor, but you sometimes require funds from other sources who are willing to kickstart a movement. The energy to get a motion going can be profound. But once the motion is already going, it's quite less to sustain it. Accountability is the word. I'm not able to suggest other ways for you now, but at least I know that when we happen, we're looking for funds. If we're accountable, they do OPRs, they give you more funds and from various sources. So you can mobilize people if you can prove that you look after your fund and is applied to what you're asked to do. There's little fund everywhere. I mean, paucity of funds. You have to bake a bigger bread for us to be able to do roads. Well, there's so many things we love in Nigeria. There's no fund. And so when the government is doing road, there's a crack there. When it's doing how health, the cloth is carried somewhere, you want to tie it there. The truth is that we don't have enough funding. We must work a bigger bread. Then we can share a bit more. Thank you. Otherwise, it depends on people.
Thank you very much.
Have I answered your question?
Yeah,
right,
thank you very much, sir.
Okay, so just to round up, because I know we've overshot our time, I would ask this same question to all the representatives of governors. What message would you take back to your governor on how to prioritize, or what you took away from this session, or advice to him in order to prioritize or increase the movement toward UHC? That is to Ekiti State, Delta State, and Osun State.
Thank you. I think the first thing is, I mean, it's obvious that the conversation needs to continue. Like I mentioned earlier on, His Excellency Dr. John Kayode is pro-health, pro-human capital. So it's not really new for him, and it's just to reinforce the message. I think maybe one thing else that might be helpful to discuss, or maybe just to bring out here, is even us in the sector, we need to rethink the way we put out the questions that we ask. And I say this because if we take 2 steps back, in reality, over the last 3, 4, 5 years, we've mobilized significant amount of resources into the health sector, right? The guys in finance, the guys in the presidency have actually heard us. Governors have actually heard people in the sector. If you look at the BHCPF, it took years between 2014, but we got the money released in 2018. The same government put over $1 billion of Nigerians' money to support routine immunization through the Gavi expansion, right? We've got additional resources from multiple sources to ensure that we provide services within Nigeria. Our current GDP numbers show that, you know, the health contributes 4.92 this year. That's an increase of about 3%, about a little over 3%, right, for 2021. So the money is sort of there. There's a question that we have to ask is, how do we begin to move away from this constant normative approach that we take, which is give us more money or people are dying, right, to a way that it makes sense to the guys in finance and to the presidency. So what's the narrative that we need to take? The finance guy is constantly looking at the GDP numbers and is asking himself, agric is doing the numbers for me, I should put more money into agric. The service sector is doing more numbers for me, I should put more into the sector service. But we come as health people and say, give me more, but we're not demonstrating much, right, to show for it. So on the BHCPF, for instance, where are the numbers do we have to be able to show to the guy in finance? Okay, yes, you gave me 18 billion. Ideally, I requested for 51, but that 18 billion have treated X number of persons, right? And 50,000 or 100,000 women have been delivered. I'm not sure that we have that number here, right? Nobody has come to say, they're saying what COVID has done, right? There's the gift component, but there's also the cost component. And for the gift is a significant amount of resources that's come into the sector. We saw in, I think it was Olumide's presentation, that the budget for the capital budget for 2021 in the ministry, 22 or 21 in Ministry of Health has increased about 80%. What do we want to show for it? So let's go back as well in the sector to rethink how we also want to ask this question and what we want to be able to preach to our colleagues in finance and our principals. Thank you.
Thank you. For Delta State, it's for us to continue to improve on our processes and ensure we increase our coverage, particularly reaching out to the people in the very rural communities, ensuring that no one is left behind. Thank you.
Oh, thank you so much. And for us in the state of Osun, the message is simple. That there is a big correlation between health and politics. You know, as we all know, we are in the era of politics in my state now, and I suppose we take it as well. You know, with what we have done in our state, we need to take advantage of this COVID. You know, we learned today that NHS came into being after the Second World War. You know, with what we have achieved in our state with this COVID, as devastating as COVID is, there are still some little advantages therein, because most states have developed their infrastructure and all that, especially during this COVID. So the message for my governor to continue with what we are doing, play more emphasis on the health of our people. If we so do, it will pay emphasis on the health of our politics as well. Thank you.
I think Senate President was here, but I think we need to hear some brief from what take home to.
Thank you. I think the take home is that unless we have the onboarding of everybody is mandatory on the health insurance schemes, we're never going to achieve universal health coverage. It must be mandatory, and there must be, like my colleague up here said earlier, we must be able to ensure that when the governors do sign up, there are consequences to not paying for these services. We have to just be able to ensure and hold everybody accountable to such things. And I keep repeating the same word, advocacy. Awareness is key. Awareness on all levels is key. Awareness even down to the grassroots level. The people or the vulnerable people that you're trying to get onto this scheme also need to understand the importance of this scheme on their daily lives. How does it affect my life on a daily? What does being onboarded on health insurance scheme mean to me? Yes, I pay this premium of, for example, 300 Naira a year, and I haven't used the scheme for 3 years. How do you make sure that these people keep paying for these services? Because one day they're going to need it, and they will see the advantages of being on such a scheme. So we must keep that awareness going. Engagement with the politicals also is very important. Constant engagement is very important, and accountability. Thank you.
Thank you very much. I think Auntie Moji will summarize in 2 sentences.
2 sentences? I'll try. Well, it will be fulfilling for me when you can carry your insurance card and be able to access treatment in any part of this country. It won't matter where you had registered or where you had enrolled, but that you can get quality health care anywhere. Like I do with my national health insurance in England, I could go to any city and there and get care. That is my hope, and probably one of the major reasons we have this convened. Thank you.
Okay, so I've been mandated to take 2 questions from the audience before we close out. If you can just raise your hand. Okay, 1 and 2. 2 ladies. Huh?
Thank you very much for the opportunity. I was just doing that side comment with my colleague. It's actually awesome to see states stepping up. And I want to take the sentence from Delta State saying, we really can't achieve UHC until we have an holistic health insurance plan. We started that trajectory of the National Health Insurance Scheme. That was a shared vision we had of a one Nigeria, where one card can take me any corner of this country. And the dream was that all of us will contribute to that. All the states, all the world, and everything you have that central pool. We've gone wrong because we've fragmented it. And it's fragmented, that's the truth. If I am in Lagos and I have the scheme for Lagos signed on, I can't benefit outside Lagos. Nigerians, we move. Our social capital is enormous. I'm sorry, I'm a lone voice in this. Can we redesign and come back together as one Nigeria? Thank you.
So hopefully in the next panel, your question will be answered because we have the Executive Secretary of NHIS, Professor Sambo, sitting in front.
Good afternoon, all. I won't take your time at all. I have just 2 points as a political scientist and political economist. I believe strongly that healthcare and this political economy has a lot to do with the political class. And I've heard all day about political will. There can be no political will without political pressure. I repeat, there can be no political will without political pressure. And a round of applause for my own Sisi Moji. She's still a Sisi, even if you see her as a mama. Because to put up this kind of show, not a talk shop, it's not easy. For one person and if a coterie of a few individuals, another round of applause. My accolades don't come cheap, and those who know me know that. So I'm not saying this for showbiz. So there can be no political will without political pressure. And this kind of forum will keep the pressure of the political class from election to election, from year to year. And I'm putting this around Sisimoji's neck. For the next election, the political pressure must be on. You must tell us what you are going to do in the health sector. Number two, health security is just, as a political scientist, I know that health security is just a part of human security. Education security, perimeter fencing security, that is security in your home with your two eyes open. But without health, we know that the productivity of any populace is jeopardized. And therefore, the momentum must continue. And this is just a beginning. And we should keep pushing. I have so much to say, I'll stop here. I thank you so much. Well, lastly, conflict transformation is enhanced. That's just the last line. I'm not saying anything after this. It's enhanced when we have universal health coverage. There's less conflict in the society because each person, the disabled, the disadvantaged, women, children, people without a voice, can stand on their 2 feet because they are fit. And health is not just the absence of disease, it is well-being of every part, mental, physical, etc. Thank you.
Sorry, one last. Wait, no. In front here, please. To the gentleman in front, on the second row, please. Second row, in white. Thank you.
Thank you very much for the opportunity. I'm not sure if this is a question or a comment. I think our political leaders may want to consider this issue of universal healthcare as an opportunity on 2 fronts: to provide health for the people, but also as an opportunity for job creation. Because when you look at what is involved in making this happen, you will need a huge IT infrastructure, which will give an opportunity to a lot of our youths to develop software applications, and various aspects of healthcare will come into play as it is in other parts of the world. I hear people say they want policies in Kano, in Niger State, in Ondo State to be applicable everywhere. But how do you make that happen without verifying whether that person is truly insured, is up to date with his premium, if you cannot gather the information? And the easiest way you can do that is through IT. And we are in an age of technology, so we must not miss that opportunity. And I think those are things that our political leaders should take on board, that this issue has a multifactorial benefit. Thank you very much.
Thank you. Unfortunately, because of time, for the journalists, we really appreciate you being here, but we would like to kindly ask if you can meet some of the panelists one-on-one after, with the exhibit, so that the next panel can start. Having said that, again, I want to say thank you so much, Dr. Gwaza. I don't know if you have any last comments, but thank you so much to all the panelists for the contributions. I think this was
Thank you.
Really fantastic.
I also want to appreciate the panelists. It's not easy to represent somebody. You have to be mindful of what you said, but they are open, at least, so that they are not committal. But we have learned a lot. The key message here is health is political, and politics is health. So we need healthy politics, but only when we are healthy. Thank you very much for your time. Thank you.
I think the panel deserves a greater round of applause. Okay, photo ops opportunity for the panelists. So while the panelists are taking a photograph, let me introduce our next section. It's going to be a very, very exciting one because it's going to be a professorial lecture to be delivered by the Executive Secretary of National Health Insurance Scheme. When we are designing this program, members of the planning team actually asked me to appeal passionately to the prof because the prof is very passionate about this. If prof has to start explaining NHIS, probably we'll still be here till 6 p.m. So on behalf of the committee, I'm appealing to the prof in advance. He's going to deliver his well. So this section will be looking at what are the policy instruments, available policy instruments for what we call subsidization, which means how do we support people to be able to access healthcare? If you are looking at health insurance, even if you say the premium is 1,000 naira, there are Nigerians that are not able to afford it. So we will be looking at what are the available policy options, how effective are they, and what are we going to do to solve some of the problems around them. So in terms of the policy option, we are looking at the Basic Care Provision Fund. We are looking at the national level, Equity Fund, which is part of the State Health Insurance Scheme. And then a number of our development partners, they've started putting their money in terms of buying health insurance premium, and we have experience to share. So without much ado, our time is already fast spent. I would like to invite, please somebody should upload Prof's presentation. I would like to invite Professor Nasir Sambo, the Executive Secretary of the National Health Insurance Scheme. I really apologize. He has been waiting patiently to deliver this. So this is the man saddled with responsibility of taking us to the universal health coverage promised land. You are welcome, Prof. Please, welcome, Prof. Please. Thank you.
His Royal Highness, the Emir of Shanga, distinguished participants, let me align with existing protocols. I have been asked to come and talk on implementation of the Basic Healthcare Provision Fund, which is supposed to be one of the subsidy programs that is designed to cover the vulnerable segment of the population in Nigeria under the National Health Insurance Scheme. I want to adopt some slightly simple outline to give an introduction and also trace the say 1 or 2 words about the National Health Act and talk about the Basic Healthcare Provision Fund, the NHS Gateway. What else should we know? And I will conclude. 400 million people worldwide lack access to basic healthcare provision fund and lack of healthcare services, despite global declaration of sustainable development goals, which entails that nobody should be left behind in the process of getting healthcare delivery services. Estimated economic benefit of investing in health is 10 times greater than cost. Hence, the global push for countries to invest in sustainable domestic funding. What we are trying to allude here, we have to invest in healthcare. And if you fail to invest in healthcare, you will be caught with a situation whereby you have to spend 10 times the money if you are into problem. And we have seen that very vividly in COVID. If we had invested our resources effectively in the healthcare delivery services, we wouldn't have spent over 900 billion naira. And 900 billion naira that is so expended now has not even in a way go into addressing the fundamental problem of the healthcare delivery system. And this is why we must be constantly investing in our healthcare delivery system. About 200 million SDG 3 ensure healthy lives and promote well-being. That's why if you look at the transition between Millennium Development Goals, which has 8 goals, 18 targets, and 8 goals, 18 target, and 48 indicator, when it is transited into Sustainable Development Goal, the SDG 3 is talking about how do we ensure healthy lives of the population. And we need to be acquainted with the fact that 200 million people worldwide are pushed into financial hardship every year due to out-of-pocket expenditure. There are so many indicators, healthcare financing indicators, which we must acquaint ourselves with them. One of them is a proportion of the people that are spending money out of their pocket. If you look at the assessment of healthcare system or assessment of healthcare financing option, out-of-pocket expenditure is very, very retrogressive. There is no equity. Therefore, when you are bedeviled by out-of-pocket expenditure, you have a tendency of being pushed into poverty, and poverty will push you into ill health, and ill health will push you into poverty, and you continue to go into the vicious cycle of disease, ill health, and disease, poverty, and ill health. And when the household is spending 20% of its earning on healthcare, that household is risk being pushed into financial catastrophe. That is what is called catastrophic health expenditure. And once you are into catastrophic health expenditure, you are going into poverty, and only God will save you. Unless if you have probably subsidy program that we are going to discuss here, and we have political commitment by everybody to support the subsidy program and ensure that those people that cannot afford are fully protected. There are other indicators of healthcare, indicators of healthcare financing, which I think we should go and read. Because the file has run me out in issue, I will quickly move into the issue that has to do with addressing those poor indicators. But it is important to note that if you look at the healthcare financing indicator, especially that has to do with out-of-pocket expenditure, Nigeria is among the countries that ranks high in terms of, according to the National Health Account Report, Nigeria is, 70% of Nigerians are spending money out of pocket to get health care. The National Health Insurance Scheme, is specifically designed to address the issue of financial catastrophe, to among other things, the most important factor, to protect the family and individual from getting into financial catastrophe. So fundamental thing that NHIS does is to ensure financial protection and ensure equity in financing. The discussion is not about National Health Insurance Scheme, so I will skip the other slides and move into the National Health Act. In the year around 2000, recognizing the deficit in our health policy, in our constitution, Nigerian constitution, it was discovered that health is not properly represented in the health in the country's constitution. Therefore, there was a need to develop a subsidiary law that will support the implementation of healthcare delivery system. So National Health Act was muted initially by a group of His Royal Highness, which worked assiduously to ensure that there is a National Health Act, which is supposed to be a complementary law to be able to redefine and clearly outline the roles and responsibilities of all actors in the healthcare. And we had an opportunity within that law that not less than 1% of the total budget, federal government budget, was inserted. And that 1%, not less than 1%, is to go into the healthcare delivery system. Specifically, that 1% was to help in strengthening primary health care and also provide access to the vulnerable segment of the population. The way it is supposed to work is that 1% is coming. Part of it, about 45% of it, will go to the NPSCDA to address the issue of supply side. And 50% of that money will come to the National Health Insurance Scheme to address the demand side. But if you look at it, the totality of the resources that is coming, whether from the NHIS gateway or from NPSCDA gateway, invariably it will land into the primary healthcare facilities. Because if an individual is covered under the Basic Healthcare Provision Fund, and the mechanism of delivery of the Basic Healthcare Provision Fund is such that this this money from the federal government will come to the National Health Insurance Scheme and have it is the destination to the primary healthcare facilities through the state health insurance agencies. So the vulnerable will be covered, and the money will go into the primary healthcare system. It will ensure that drugs are provided, and drug is one of the most consistent and sensitive indicator of healthcare delivery system. A study long ago has been conducted by World Bank that where a facility run out of basic supply of drugs, that facility tends or a risk losing 70% of its clientele. So the whole idea of this 1% is to move that resources into the primary healthcare, strengthen it, creating geographical and functional access, and also provide financial access to the members of the vulnerable population. So the Basic Healthcare Provision Fund is to be delivered by ensuring that minimum healthcare package is provided to all the enrollees under it. It has also provision for emergency medical treatment. That's the 5%. 50 NHIS, 45 NPSCDA gateway, 5% to go to the emergency EMT. You'll hear Federal Ministry of Health talking about emergency. Because whatever emergency gateway, whatever services we deliver, if we don't address emergency, we will not be able to reduce the mortality, the increasing mortality we have in our society. That's why the EMT gateway is also important. The milestone, it is important for us to also understand the milestone of the Basic Healthcare Provision Fund, which we will conveniently say it starts by the year 2014, when the National Health Act was signed into law. And by 2015, the issue of decentralization of social health insurance scheme came in, whereby states who were initially or hitherto reluctant in joining the National Health Insurance Scheme, as being alluded by one of the participants, they were now asked to. It was decided at the Council on Health that the state should establish their own health insurance agencies, so that they can benefit from the Basic Healthcare Provision Fund. And any state that has not developed the social state health insurance will not benefit from that federation money that is coming from the consolidated revenue account. In 2016, NPSCDA, NHIS, and Federal Ministry of Health developed a guideline manual for implementation. That manual for implementation has started operating, but unfortunately it was stalled. Why was it stalled? When I came to the National Health Insurance Scheme as a CEO, I met that there has been a lot of controversy in that manual. And when I look at the manual, I align myself to the people that are promoting that controversy. Why? Because that manual is not in alignment with the business processes of NPSCDA, neither was it in alignment with the business process of the National Health Insurance Scheme. So eventually, you will have a situation whereby you are operating a vertical programs under our system. And secondly, the benefit package that was encapsulated in the manual, I quite disagree with the fact that you need to cover more people, therefore reduce the benefit package and cover more people. It will amount to deception. You have a program that you say you are covering people, and when they come, they just get some few services of malaria and so on and so forth. The National Assembly said that they are not in alignment with that. The Honorable Minister of Health also says he is not in alignment with that. We should have a modest benefit package for people that should come into the national that should benefit. Not to say that we have a formal sector with a robust benefit package, and you have a subsidy program with a very limited benefit package, and you now say that you are covering people. When you are covering people, somebody has appendicitis, acute emergency, you now tell him that you cannot cover him. And when somebody has malaria, upper respiratory tract infection, you go and you say you are covering him. That will amount to deception. So we align ourselves to say that if you are coming to the Basic Healthcare Provision Fund, you should have some good benefit package that can take you to primary healthcare. Where the need be, you can go to primary healthcare and do some emergency. And in any case, if you are just covering cases that people can spend their money on, and when it comes to cases that they cannot be able to handle, you now tell them that they cannot get services. I think it will create crisis into the system. So it is good that the National Assembly made that observation, and the Honorable Minister stood firmly to ensure that that manual is modified to develop the new guideline, which has been approved by the National Council on Health. Gafar, I hope you are not coming to tell me that. So I was okay. And it is important that people should study the manual and study the guideline so that people can have an informed decision. There was a lot of cat and mouse game between the ministry and partners. And the minister insisted, and even he set up a committee, and that committee consists of commissioners and all the stakeholders, and we all agree on the new guideline. So please and please, let us support that guideline. Let's continue to see how we implement. The onus of mobilizing more resources for healthcare is left on us, who are the policymakers, who are supposed to guide government in creating innovative financing mechanisms that will bring about people to get healthcare delivery services. And I'm happy that this thing is happening with the theme of universal health coverage. One of the key issues, what are the totality of effort that we will do to ensure that we mobilize resources for attainment of universal health coverage? It is left for us to think collectively. The National Health Insurance, NHI's gateway, I told you it received 50% of the total fund that is earmarked under the National Health Act. And what are the activities that the National Health Insurance Scheme does or do? Number one, development of implementation documents, M&E tools, quality assurance tools, protocols, as well as accountability framework. Because health insurance scheme cannot be implemented in an atmosphere of ignorance. Health insurance scheme is one program that you must have very, very clearly defined protocol for implementation. You must have a very good protocol for monitoring and evaluation. And you must have a very good accountability framework, because money goes in, money goes out. If there is no accountability framework, health insurance system will collapse. So we have to sit down and develop all the necessary tools and develop all the necessary tools that every actor in the sector will understand the ABCD of its implementation, so that nobody will be left in doubt as what is his role and what is his responsibility. Number two, health insurance, you have to build robust capacity. Without capacity, without developing capacity, there is no way health insurance scheme can work. It will start and collapse. Because it's one of the most complex systems to manage. As a manager of healthcare insurance, you have to have some good knowledge of actuary. You have to have a good knowledge of financial management system. You have to have a good knowledge of healthcare delivery, including epidemiology and other skills that is necessary. Otherwise, you start health insurance and it will not go anywhere. It will not fly. The next thing is accreditation. The next thing is accreditation. You cannot commence health insurance without accrediting healthcare facilities and ensuring that there are standards. Those standards are a framework that will provide quality care. Because in health insurance, even in the basic healthcare provision fund, which looks like a free program, but it's not free. Because government is saying we are paying for X number of people. And when we say we are paying for X number of people, that X people, everybody will have an identity card. So he has a right. And he can claim, he will come back to claim his right. Because if something is done to him that is not intending with what his expectation, he has right to complain. That is one of the difference between free health. Some governors in years back, they have practiced free health. Many states have passed law of free health services. And you go to hospital, you don't get drugs. And there's no way you can complain. But in health insurance, once you have identity card and you go to healthcare facility, no drug, you will complain. In fact, that's why every health insurance will have an enforcement unit or enforcement division, which will track whatever is going within the ecosystem to ensure that no enrollee is shortchanged. So you need to accredit healthcare facilities. And you know, the normal tradition of healthcare delivery system has not factored in accreditation of healthcare facilities. In fact, we began accreditation of healthcare facilities with the advent of the health insurance system. That's why one of the objectives of health insurance is to improve quality, because it will there must be standardization. So this is one of the activities we did. And lack of accreditation is even more deeper when you go to primary healthcare system. But we have to utilize primary healthcare system as an entry point to the basic healthcare provision fund. The next thing is enrollment. You have to enroll people. And in the process of enrollment, you have to ensure that there is no duplication, no overlaps. And therefore, you need to have a robust system that will facilitate the enrollment. That's why I like the comment by the last contributor, who alluded to the fact that even to be able to access services everywhere as being proposed, you need to have a robust digital technology. Without digital technology in the 21st century, you cannot have an effective healthcare delivery system. Neither will you have effective health insurance. Quality assurance is one of the key activities that we do to ensure that we interface with the healthcare facilities and be able to identify quality issues that will allow our enrollees to get better services. And of course, monitoring and evaluation. The whole essence of the monitoring evaluation is to be able to detect any problem and come back to see whether you can address the problems. I'm sure when you do this kind of presentation and you didn't talk about money, people will be sleeping. But now I will be talking about money and people will be awake. The disbursement. I told you that when we receive money in NHIS, we disburse to the State Health Insurance Agency. That is what the guideline says. And when the state receives the money, they will now be paying for services either in form of capitation or in form of fee for service. So far, NHIS has disbursed about 14.9 billion naira to states, and the distribution is there. If you want the distribution, to see that the distribution according to state, when we finish the presentation, the head of ISD in NHIS, Mr. Pharmacist Indiaka, will furnish you with that. Health insurance, ladies and gentlemen, this is important, it's not free. It has to be paid for, and it has to purchase giving a defined benefit package. And there must be a definition of what constitutes benefit package. And there must be how much to be paid to purchase that benefit package. So the money that we have received, we are expected to cover about 1.2 million people. And you all know that the estimated total population of poor people in Nigeria is put at about 80 million people. So whatever basic healthcare provision is presenting on the table is far cry to what we require to cover the vulnerable segment of the population. That's why we need to crack our brains to see what other innovative financing we require to do to mobilize that money. So this is some of the NHIS gateway and milestone we have done. The slide will be available for people to understand what we have done. And I will quickly go into the nitty-gritty of some of the activities we did in terms of the number of healthcare facilities we have accredited. Please, can you go to the next slide? Next slide. This slide shows the number of healthcare facilities we have been able to accredit. Like in Abia State, we have accredited 262 primary healthcare facilities to utilize in the provision of healthcare delivery services. In Kano, we have accredited 497 healthcare facilities to be eligible to provide services under the Basic Healthcare Provision Fund. The next slide shows the target of what we are supposed to cover in every state and how much has been covered so far. The blue line is showing the target population. Like in Abia, based on what they have received, they are supposed to cover about 50,000 people. And so far, they have enrolled almost close to 50,000 people. So Abia is doing well in that regard. For Kano, they are supposed to cover about 80,000 people, and we have covered over 50,000 people so far. You know, enrollment is gradual. What stole our enrollment drive was initially we said that for anybody to be enrolled, he must have a NIN number. The purpose of the NIN number is to ensure that there is no duplication. But unfortunately, when we started for some months, most of these rural community people have no NIN number. And to get NIN number, it was becoming difficult. And we were under intense pressure to start cover. So we now give a waiver to say that let's start enrolling, and later on, they can develop the NIN number, because we can't keep on keeping money because of one rule. Our people are dying, our people are not getting enrolled. So we suspended the use of NIN to ensure that we enroll. And you know, this enrollment is not that you just come and all of you are enrolled. You have to, there are enrollment tools which people have to be captured. The ID card will be presented. So it's a gradual process. Then the green line, I say, is the number of enrollees. There are some states that have not yet started enrollment, like Akwa Ibom. We have not received data from them. Like Oyo, even though they say they have started, but we have not received data. We are only using the data that the state that have supplied us with data. Rivers and Taraba, they are yet to start enrollment. Last 2 weeks, I was in Taraba. We went to the Honorable Minister to commission one of the primary healthcare project. I had a discussion with the Commissioner of Health in Taraba that they will soon start. But it is important to say that Akwa Ibom and Rivers, they are yet to develop their own state health insurance agencies. Apart from enrollment, people have to start accessing cover. You see, there could be a mismatch between the number of people that enroll and the number of people that have started enjoying cover. Because health insurance, you have to be sick to go and seek for cover. And secondly, there is need for effective information and communication to people. It's not just to go and enroll people, you have to educate them on how to access services. So we need to do a lot in terms of information, education, and communication for the people to get to know what the scheme is all about. And this will take time and a lot of effort. And that's why we will like people like Boji to come with our experiences to see how state can be supported. Because when we are talking about universal health coverage, we are talking about three things. population coverage, service coverage, as well as financial protection. That's why health insurance is very, very critical if you look at the three elements of universal coverage. Because using the financial system, it can catalyze all the other two elements in universal health coverage. What are some of the takeaway that we need to do? That we need to take? The advent of basic healthcare provision fund has catalyzed establishment of state health insurance agencies and has stimulated the states who have been in slumber in the area of health insurance to wake up. So this is a very good advantage because of the basic healthcare provision fund. It has also provided, it has so far provided access to over 500,000 indigents in the country, which leads to financial protection. Never in the history of Nigeria we have had this kind of opportunity, whereby vulnerable segment of population are coming under the spirit of human right to be getting services. And if we do basic healthcare provision, if we get it right, I want to tell you that it will sell itself. Wherever you have health insurance that is working, it becomes a political tool. You either, if you are a politician, you either support it to win election, or you go against it and lose election. That has been the history of health insurance right from the beginning. The basic healthcare provision fund has provided opportunity for us to restore primary healthcare system, because we have opportunities whereby money for the first time is going directly into healthcare facilities. The management of primary healthcare system in the past is that they are supposed to benefit from the budget, which they will never see, or they have never seen. But the basic healthcare provision fund has provided opportunity for the healthcare facilities to be getting dual funding. One from the primary healthcare system on the aspect of supply side. Second, from the health insurance, from the demand of services that is being paid at that level. The advent of the basic healthcare provision fund has stimulated the issue of quality assurance, which was never hitherto factored in the healthcare delivery system. Now, primary healthcare system are being standardized, and you know that structure is one of the first component of quality assurance according to Avedis Donabodian. It has started creating community awareness in the area of health insurance. What are the initial challenges that we are encountering so far? The release of the money or the fund for the basic healthcare provision fund has not been consistent. And Senator Olorebe has alluded to that fact. But we are trying to put our acts together so that we will have a continuous flow of this fund without any hitch. Number two, low level awareness. I have alluded to that. We need to create awareness. We need donor agencies. We need civil society organization to help us in creating massive awareness with respect to the basic healthcare provision fund. We are also having some challenges of weak political and financial commitment from some states, especially in the area of paying for equity fund, because the basic healthcare provision fund entails that some equity fund should be given. In fact, the other time I met the governor of Enugu State, I was trying to tell him in a simple language how he can understand and invest money in the basic healthcare provision fund. I told him that this money that is coming from the National Health Insurance Scheme, Gateway, is a federal government money. It's a money from consolidated revenue account. It's not money from federation account. So it's the federal government contribution towards expansion of care. And this must be understood by the governors. And I told him, here you are. Federal government has given you money to cover 3 people. And they say that for you to benefit from that fund, you pay for 1 person, which is the equity fund, 25%. For every 3 people, bring payment for 1 person. What is difficult in that? And if you don't pay that equity fund and it is a criteria for disbursement, you will not be entitled. Do you want to leave your own people not to benefit just because you want to match 3 for 1, 1 for 3? Poor supply side readiness and lack of synergy with demand side in some states. When we went out to do accreditation, we realized that so many primary healthcare facilities are not in good shape, and therefore will not fulfill criteria of registration by the National Health Insurance Scheme. Another challenge that we have encountered, the initial 3 states, Abia, Osun, and Niger, were supposed to be World Bank pilot communities. But because of the modification in the guideline, World Bank decided to withdraw its fund. So the states who have started enjoying the World Bank support abruptly had that agreement terminated. That problem is now being addressed at the level of Federal Ministry of Health. We need to have presence of commercial banks in some communities so that the money that goes to the facility can easily be accessed at that community. But in some community, there are no commercial banks. They have to travel a very long distance to complete financial transaction. And lastly, the challenge of insecurity. Insecurity is creating an obstacle for some of the states to penetrate into some areas. Areas that are ordinarily not hard to reach. What do we need to do? What do we need to do? What else do we need to do? We have to work together to ensure prompt release of basic healthcare provision fund, advocacy at all levels. And I'm sure Dr. Gafar can develop a very robust advocacy team that can start talking from the gateways up to the presidency. I'm sure you have the capacity to do that. We need to deepen advocacy to the state governors. We need to ring the bell. This is a people-oriented program, and they need to support it. And they need to invest in it. If you invest in healthcare, if you fail to invest in healthcare, we have shown that you will come to spend your large chunk of money in trying to do a damage control. We don't want them to be doing this damage control. We need to support the mandatory social health insurance scheme. That is the final answer. Final answer, mandatory health insurance scheme. If we have that law passed, there are so many mechanisms through which health insurance money can come from health insurance. I forgot to tell you some critical principles of health insurance, which if you are operating health insurance, if you don't know those critical principles, you might not get it right. One of them is ability to generate big pool. Because insurance generally relies on pooling of resources. The bigger the fund, the more ability to do the second principle, which is cross-subsidization. Without mandatory social health insurance scheme, we will never have that food, and we will miss the opportunity to do cross-subsidization. Cross-subsidization is when you pull the risk and you pull the resources together so that today Mr. A is sick, you are using Mr. B and C's contribution to cover for Mr. A. And next 3 months, Mr. B will be sick, and you use Mr. A's contribution and Mr. B's contribution to cover for Mr. B. That's how, that is the philosophy underpinning principle of social health insurance. So we have to advocate for mandatory health insurance. And I'm happy the legislators have given us 100% support. In fact, the 8th Assembly have passed that law, but it was not assented to. This Assembly have passed it without any difficulty. Massive awareness creation. Massive awareness creation. And this mandatory bill, that is before, that is just passed as alluded by the Senate, by Chairman Senate Committee on Health, it has provision for vulnerable fund. That was not what we wanted. We wanted 1 kobo per second call. Because we have done our arithmetic. When you take 1 kobo per second from telecommunication, nobody will feel that something has been deducted from his call. Because do we have 5 naira? Do we have 5 naira denominator now? And do we have 5 naira denominator? I'm asking a question. No. Do you have 50 naira denominator? Do you have 5 naira? I don't know when last I saw 5 naira denominator. So 1 kobo per second, even if there is 1 kobo per second, you have to divide that 5 naira per 1,000 to just drive 1 kobo per second call. But it has tremendous capacity to bring huge resources in billions, which can be put to cover the vulnerable segment of the population. Ladies and gentlemen, if we are going to do advocacy, because Nigeria is one of the signatories to Sustainable Development Goals and in effect to achieving universal health coverage, therefore Nigeria has to finance it. And we all know that the vulnerable cannot afford to pay. We have to devise a mechanism of paying for them. And we say 1 kobo per second call. I have gone to Rwanda last month and I realized that they are doing a kobo per second call. So why not Nigeria? Massive awareness creation, another important thing that needs to be done. So ladies and gentlemen, because the file has forewarned me, and I wanted to be a good lecturer, I have heed to the warning, and I thank you very much for listening.
I think Prof deserves a better round of applause, please. I'm very sure having listened to Prof, I think each and every one of us deserves a certificate in health finance, right? Do we? Okay, so let's appreciate Prof once more. I think this is a presentation that slide deck that everybody should have, because I find it very educative in terms of telling us. Profs, one of the challenges with the Basic Care Provision Fund, people are struggling to understand. People are struggling to understand where we are, and your presentation has actually breached that information gap. Thank you very much. And again, for those of us that are involved in advocacy, we have a clear picture of the advocacy needs now. So I would like to crave the audience of the House. I promise you in the next 30 minutes or thereabout will be done, and we're done with this exercise. So in order to examine some critical issues, we need to bring some panelists to look at it, but just not too many people. We don't need to bring, the initial plan was to bring Prof to the panel, but the question is that what else do we still want to ask Prof? So he has answered the questions before we even ask them. So thank you very much, Prof. So quickly, I would like to introduce the panelists and the moderator as well. Dr. Francis Wahindo is going to moderate the panel quickly. Dr. Francis, come on board. And then we have Dr. Ahmad Abdul-Wahab of Nigerian Governors Forum, Obili Olichukwu from Christian Aid, Dr. Amina Balodin, the Honorable Commissioner for Health, Kaduna State, Honorable Mohammed Usman, and Dr. Alasan and Yusuf. Yusuf from BMGF, if we have, let's quickly have maximum 20 minutes. I promise you, please, I'd like to crave your indulgence. Let's have this panel discussion quickly. Dr. Abdul-Wahab, please, and Yusuf, please, let's quickly have this conversation. I will co-anchor with Dr. Francis. So Dr. Francis, just a question for each of the panelists, and we throw it open, and in the next 30 minutes we are done and we close this section. So Dr. Francis, over to you.
Yeah, thank you very much, Dr. Gafar.
And then we have a couple of people online. If Nkata is there, you can contribute, and Dr. Sam Albo as well, if you are online. So Dr. Francis.
All right, thank you, Dr. Gafar. Good afternoon, everybody, ladies and gentlemen. We've heard it all. I'll put it that way from the professorial level. Professor Nasir Sambo was also my teacher in school.
So Dr. Francis, please, you are encouraged to take off your mask while speaking. Omicron is suspended.
All right, thank you very much. Yeah, so like I said, we've heard it all from Professor Nasir Sambo, and it's interesting, really. If you really want to understand universal health coverage, it's a very, very wide area. And but the things to be done are few, and those things need to be done very well. And one of the things that we need to start looking at is also looking from amongst ourselves, policymakers, and what George Bush used to call coalition of the willing, to see how we can make sure those things are done right. So the panelists here actually represent sort of a sort of cross-section. Dr. Nkata is not online, he's here. You said Dr. Gafar, Nkata is here.
Okay, great.
Yes,
so
he's not online. It's good to have you here, Dr. Nkata. We thought you'd gone. Okay. So quickly, I will not go into details. I think we've had most of the issues. I'll just ask some of the panelists here to give us some insights around certain key questions. And I will start with Ahmed, Dr. Abdul-Wahab of the Nigerian Governors Forum. Yeah, I think for us, that perspective from your side is very, very critical. Looking at what the issues are, looking at the fact that subnational level is the implementation or ground zero of implementation for health insurance, and also achieving universal health coverage. So for us, we would like to know from your side, in terms of how the Nigerian Governors Forum is working towards improving the idea and gaining momentum on the idea of universal health coverage on the side of the governors, and also looking at how the issues of release of equity funds have been like at subnational level. I think that we can start with that. Dr. Abdul-Wahab.
Thank you, Francis, and thank you for inviting me on this panel. I think the question you asked me, thankfully, you've had some state that spoke earlier on. You heard directly from Dr. Ben of Delta, and I think you heard from the Deputy Governor of Nasarawa State in terms of what they're doing at the state level. So for the Nigerian Governors Forum Secretariat, in terms of health, we have 4 areas of priority. And the first one is actually universal health coverage. And for some of you that must have seen, in fact, the NGF released this chairman himself released a press conference, a press release this morning in terms of aligning with what is happening here and saying what in terms of what the Nigerian Governors Forum is doing. So the forum, in terms of universal health coverage, try to unbundle it into three key areas. Having access to quality services is the aspect of the primary health care under our roof.
Sorry, Dr. Ahmad, can you remove your mask while speaking, please, if you don't mind?
I mind actually.
Okay, go ahead.
But so that we don't say we are breaking COVID protocol anyway. No, that shouldn't be that. Okay. So I was saying the UHC, so we're looking at it from three perspectives. Provision of quality services, so trying to advocate for primary healthcare under one roof. Access to financial protection, which is the issue of the state health insurance, trying to actually get state insurance. And as I'm speaking, 34 out of the 36 states actually have a state health insurance scheme. And part of it is because of the peer pressure from the forum, trying to make sure that the governors actually create these agencies. But we have to know that UHC is not just about the state health insurance alone. It's just one aspect. So I just want to dwell on that aspect in terms of what the governors have been trying to make sure that each of the states have that. So that is crucial. Then for the equity fund, yes, for equity fund, we've been having different models. You're having Bielsa where they release it monthly. You heard what Nasarawa said, that they have been releasing their money. So yes, it's not all the states that have released it, but I think it's something that we continue to advocate. And then we have a tracker that we track at the Nigerian Governors Forum Secretariat to ensure that we give feedback and try to put pressure on the governors so that they're able to do this. Thank you.
On that level of updates, it's impressive that at least we have that number of states now, 34 states with state health insurance existing. But then I will not leave you yet, because since we're going to just go around and complete the panel program for this set, I think it would be good for you to give us some ideas in terms of what the Nigerian Governors Forum looks at in terms of a better way of prioritizing, in terms of making sure that we are able to achieve the kind of mileage we need for universal health coverage for Nigeria. Can you just quickly that, and so we can move to other panelists?
Right, thank you. So I think the whole aim of this summit that we're trying to engage the political class, which is something very good. That as we are going to go into political season next year, we want to make sure that the political class gets the right information. One thing that we always miss is we think the political class have the right information. They don't. And it is our own technical people that we need to get that information to them. So that's one. And then two, when we try to get the information to them, get it to them in the form that they can digest. Not the way we talk as medical people, at the end of the day, you confuse people and you panic them, and they are not able to do the right. But we have to put it in a way. We should ask ourselves, why are they able? We said there's no funds. How did we get all this funding for COVID? How did we get all the funding for polio? I think it is in terms of how the whole thing was packaged. So as we go into the political season, in terms of trying to actually get the political class, I know we said this is just the beginning. We should have series of engagement with the political class. What we should do as technical people here is we should have the menu. It's not just enough to say when you do maternal health, you're going to save return of investment of $10 per day or 40 something. That is not just enough. What are those interventions that I need to do? So I think we need to identify all those high impact interventions, list them, that these are the high impact interventions, that from this menu, you can be able to choose. If you choose from this menu, you are likely going to get it right. Because you find some states actually they're spending more than 15% on health. But when you looked at what was done, you now see that, okay, the money was actually used for something that was not maybe probably, that will not achieve the kind of milestone that you expect. So it's going to help the states, help the politicians, so that when you see politicians campaign now, they'll say, we're prioritizing health. You ask them what they want to do, they say, I'll build more hospital and I'll employ doctors. And when I hear this, I said, that one they have missed road. It's not about building hospital or employing doctors. It's about trying to articulate what is the problem and then try to see the interventions that you want to do. So I think for us here, let's get those menu right. And then when we engage with them, we'll be able to educate them on those menu, not just tell them allocate 15% to health. Thank you.
Yeah, thank you, Dr. Abraham. Well, while you were talking, I mean, coming from what I would call like a sort of confederating system in terms of the Nigerian Governors Forum, I think it would be good to also hear from the side of somebody who is an implementer on ground in the state in terms of organizing policy and making sure the things happen. We have a commissioner here with us in the person of Dr. Baloni from Kaduna State, right? Yes, so madam, so looking at the whole idea of this health insurance and then of course universal health coverage, the question I want to ask you here is that what do you think can be done at subnational level to expand access to health insurance? And what is it that you're currently doing well, you think has worked for you in Kaduna State that you think can be bubbled up to other states in Nigeria? I think that is very critical.
So I will. Thank you very much. I'll pitch my voice as one of those that says, don't remove your mask. Thank you for that question and the precedent set by Dr. Abdul Wahab. So at the state level, I'll speak for Kaduna. I think the first thing is to have the political will and follow it up with the action. So this government has consistently met and sometimes exceeded the 15% set by the Abuja Declaration. So we're prioritizing funding to health. That is important at subnational level. But where are you prioritizing those funds to? We have started the revitalization of the primary health care. This started from 2015. We have delivered one primary health care center in each ward, and we're going a step further now to start on the clinics. What is this? It gives increased geographical access. Now in 2018, the social health insurance scheme, state health insurance scheme was inaugurated. The law mandates that all employers that employ more than 10 people must subscribe to the social health insurance. Of course, you had to do the development of the package, most of end of 2018, 2019, and then we went into COVID. So enrollment was a bit slow. But what we've done in that law is to mandate 1% of the consolidated revenue fund to go into the pool for the vulnerable, specifically for the vulnerable. And this we're doing through the social register. We have a social register in Kaduna that registers the vulnerable people. We have so far about 1 million on them. We haven't completed the enrollment, but you can see that there's a systematic way of doing it. You have to identify these people. It's not at the point of giving them health insurance that you start identifying them for obvious reasons. People just slip in the names of people that you know they don't know. The other thing we've done is, like my colleague said earlier, if you don't have the quality services, and like Professor Sambo said, people will stop subscribing to social insurance, health insurance. So what we've also done is to enter into an agreement, a framework agreement with the manufacturers group to provide drugs and commodities, essential medicines and commodities. We've increased the HRH, Human Resources for Health, at that level. We've employed over 1,800. So what am I trying to say? In as much as that you want to enroll people to get services, the system must also be ready to provide services. Because if you don't, people lose confidence in the actual scheme, and getting them back now becomes an issue. So far we've enrolled about 500,000 people, but as you know, it's skewed to the formal sector. Formal sector is organized, Public sector, it's mandatory, so the government pays for them. We're having to scale up in the informal sector. If you're looking at the civil servants in the state are just about maybe what, 100,000 and their families, and we have a population of over 9 million. So the work is actually in the informal sector. And this is what we're trying to do. And we're trying to use innovative strategies. We're thinking of merging the free MCH, which existed before even the health insurance, into the pool. Of course, Professor Sambo has talked about the Basic Healthcare Provision Fund. So expanding and merging those pools, because when you have multiple pools, you dilute the effect of what can be achieved. We have to go on, of course, as he said, mobilization, getting people to really key into the scheme. One of the challenges we have is the apathy that people have towards health insurance. You know, culturally, we're quite fatalistic. We think, oh, if I was meant to be sick, I'll be sick, or it's not my portion, so I don't have to prepare for being sick. So those are some of the things that we're coming up against to make sure that, you know, we're trying to work on those. We're also trying to enforce the organized private sector that employ people are reluctant to join the scheme. So we have enforcement issues. Our package we have seen from utilization needs to be tinkered with. The package costs about 10,500, but we have seen, like Professor Sambo said, that some of the key things are not covered, and that is pushing people, you know, not to access it. And of course, the tight fiscal space. Although we get 1% consolidated revenue fund, other people have to pay. And if there's an economic downturn where it will be difficult. So we're doing things like the tertiary institution scheme, where we're targeting, you know, people in the universities, people in the higher education facilities to see that they also key into that scheme. We're recently talking to some partners about crowdfunding. How do we get crowdfunding for people to pay for insurance for people that can't afford? And we're looking at Zakat. That is also a very, you know, big source of funding that people can commit to social health insurance. So these are some of the things we're doing. It's still a work in progress, but I think if we sustain the pressure of improving the services and mobilizing people, and as even His Royal Highness said, it sells itself. Once people know that they can get the services, they're confident that they go anywhere, they can access it, and they're happy with the quality, then word of mouth gets more people on the scheme. Thank you.
Thank you very much. I think that's very good. I was particularly enthralled by the way you describe the system readiness assessment thing or process that you put in place, especially looking at the human resource for health. But I mean, that should be a conversation for another day, you know. But looking at this, just a last word of sorts in terms of if you were to talk to the political class in terms of value for money in making sure that the state health insurance scheme works and it will bring them value, political capital, what will you tell them?
I think the first thing is that health is everybody's concern. So it's not this party or that party. As long as you have human beings, they're concerned about the health. And the sure way for you to get converts to your party, to yourself, is to make sure that people have those social services. And this is what we're also doing, not just in health, but we have a Human Capital Development Council that prioritizes social spending. So in education, in health, in skills, in water, sanitation, the very things that touch people's lives. And that you don't need to campaign over. As we've seen in the presentation, several presidents ran on universal health coverage that have come to fruition. But the important thing is if you prioritize people's health, they will surely be converted to your cause. And of course, make sure that as you do so, you deliver, because promises that are not kept come back to bite you. Thank you.
Thank you very much. Okay, so I'll go to the extreme end. Dr. Nkata. Yes, so the man we thought was online. All right, please, you have had experience of supporting states in sort of a catalytic process in strengthening their systems towards this universal health coverage agenda, whether through the state health insurance and all that. What do you think in terms of what are the lessons in terms of maintaining these elements of support for the states? What are the lessons you have learned in that process? I think that's very critical for all the actors in the field.
Yeah. Thank you very much, Dr. Francis. I think one thing is clear from the opening presentation from your Rob Yates to everyone who's spoken before now, that for funding, we definitely do need a national pool that can bring together the level of resources we need to take care of Nigeria's overall poor and vulnerable, right? But people tend to ask, what happens if you get more money through a national pool? Will the state health insurance agencies or commissions still be relevant? The answer is not just yes, but that's even when they will become more relevant. The truth is, the states do have a role to play in contributing to funding. At a minimum, doing what the Delta DG was saying, where the state is responsible for paying for its own staff, right? The civil servants. Even if federal government had enough money through BATPF or any other pool to push down for all the poor and vulnerable. But the biggest thing which we've learned can only be done locally is targeting the population. What the Honorable Commissioner was just saying, you see, you can't sit in Abuja and figure out how to identify, capture, and deliver services appropriately to the informal sector and even the formal sector at every level. And the informal sector varies from one state to the next, and even within states from one senatorial district or LGA to the next. So when you see states or even at the federal level, most people doing well in enrollment, it's all formal sector, right? So one big lesson we've learned is there needs to be that deliberateness at the state and local level. First, to identify that the formal sector is a very large group. The informal sector is a very large group. There is a huge informal sector segment that can pay, do have the money to pay. The last data from MBS shows that about 78% of all Nigerians who are in any kind of employment, not the unemployed, the ones who are in any kind of employment, are employed in the informal sector. Now, the man who has a shop in Alaba selling generators is wealthier than your bank manager, but he's categorized as the informal sector. There is a huge segment of the informal sector that can pay, that we need to market insurance to the right way. We need to show them value for paying, because such people need to contribute to the pool. And of course, there is the more obvious vulnerable sector. Kaduna, for instance, is fortunate because Kaduna has a statewide social register system that it's not just for health. It's basically a social register that just identifies those at the bottom of the pyramid so that the state can target them with different social services. We worked with Kaduna and Niger for the first 3 years when they were trying to design this scheme. Now, the lessons for us is one, understanding that sector, targeting it, because that's where the majority of the people are, figuring out those who can pay, marketing to them appropriately. The other one is, you see, this is not a sprint like Antimoji said. We have to keep using data to learn and unlearn, no matter what experiences we bring from the north or from the rest of the world. I mean, the northern pole, you know. Because if you look at Delta, for instance, one of the things that have helped Delta out is Delta started with a baseline assessment in 2015 before they actually started the scheme in 2016, right? And what they did was they looked at the demand side and the supply side. So they knew before they even designed the scheme how many facilities, public and private, were in any kind of situation to deliver services in the first place and what the challenges were. And they also had some clear idea of the demographics on the demand side. You know, what do the people think about the proposed packages, what people can pay and all that. And then 4 years down the line, they went back and did another assessment to look at how far the scheme have gone, how well those assumptions they made in designing the scheme have held up. You know, so it's not enough to set up a state health insurance agency, get the initial money from the government, throw a lot of people into the pool. The bigger challenge is to retain people. So if you don't continue to use data to guide exactly what packages you're providing, again, the Honorable Commissioner mentioned there are services. Lagos, we just finished a revised patrol for Lagos over the same challenge. People, they realize that many people don't want to get on the scheme because the services they really want are not in the benefit package. So it is better you move the premium from 10 to 12,000 and provide people what they want than you do a premium of 10,000 and nobody wants to get on the scheme. So I'll pause here for now.
Yeah, thank you. I think I hear you very well, and I think you emphasize deliberateness in terms of moving forward with it, as well as using evidence in terms of making sure it shapes your actions on the field. That is very critical. Thank you, Dr. Nkata. I want to take it to another level. We have a former member of House of Reps here, a one-time commissioner in even Kaduna State, who is with us on this panel. He has very varied experience and is a member of the National Health Advocates. I want to ask him because he's wearing the civil society cap. So it's very important we hear that voice. Honorable Mohammed Usman, I used to be vice chair of the House Committee on Health at a point for the National Assembly. So, Honorable Usman, you've heard all this. I think that we need to connect dots here. What do you think would be the critical role of civil society in all this?
Very much, Dr. Francis. I'm happy with what is really happening. And like somebody said, we have kick-started the process, which must be continued, which must be sustained. But the first thing I would want the civil societies to do is just like riding on what Dr. Abdul Wahab said, is articulating the agenda. What do we really want to achieve, you see, in health, really? Because what is expected at the subnational level could be different from the FG, you see, level. So you must articulate, you see, the agenda. What are our acts to the politicians, to the gladiators, to the political parties, to the governors? We must have our acts right. When we have our acts, you see, right, then we will be able, when we are talking, when we are engaging at the FG level, then we know precisely what to ask. And then when we go into the state level, subnational level, then we know what should be our focus. For instance, so many people here who have spoken have emphasized on the fact that issue of 15% Abuja declaration is no longer the issue, because to a certain extent, it's not funded. Funding is not a problem. We have seen it with COVID. A lot of resources have been voted, you know, into the health sector, but the money, the funds, are they being utilized in the proper way they should? What of local vaccine use production? On, for instance, the COVID, billions, like my leader, Bukola Saraki, said, you know, almost about 900 billion, close to 1 trillion naira has been voted. What do we have there, for instance, for local vaccine production? And we know precisely that one of the ways that we can really make progress is voting money is encouraging, working to ensure that we produce vaccines, our vaccines locally. Something must be done. So we must be able to articulate our agenda and get what we want, you see, to achieve right when engaging the political actors, the governors or the parties. Now, the next thing is deepening and sustaining this advocacy, which we have just, you see, kickstarted. Like Saraki, you see, mentioned, and I believe, I recall, during the process of the discussions on this summit, I did mention that we may not get the desired audience. And this is exactly, you see, what happened. Somebody mentioned, like he said, we are talking to ourselves. The real actors, gladiators that are supposed to be here are not here. I have served as commissioner. I'm not underrating my colleagues. I have served 3 times as commissioner in my state. And I know the powers of a commissioner. I know the limits. What a commissioner, you see, can do. So the governors, we must find a way of engaging them. Really. So not only the governors, but the political parties, because we are approaching election. And part of what we want, what we will really want to have, is to ensure that health issues, health is captured in the manifesto of political parties. It's only when you do that, you can have that implementation when the governments come to, when the officials, the elected people, you know, get into offices. So that is very, very important. So we must adopt strategies of reaching out. And I've said it maybe to the geopolitical zones, getting to meet with the governors, sit with them, identify the political actors, get to discuss with them in their offices, various constituencies, because something like this, they won't come. So that you, with what you have, the agenda, then you can really present, you see, to them. And we need to do this fast, because why? We don't have time. Next year is election period. Many of them may not even have time, you see, for us, really. So we must find a way of getting to them, maybe at the geopolitical level, identifying the leaders. Now I'm happy, for instance, PDP has already elected its officials. We know who is the chairman, the secretary, and what have you. So we must be able, you see, to track them to their office. Say, look, chairman, sir, this is what we want to be put in your agenda. And by the time in February, when APC has conducts its on, the officials are there, they will be able also, you know, to get across to the leaders of the political parties, to also sit down with them and give them our articulated agenda. And I think this is what I'm going to really say at this point. When I have opportunity, I would have more things to say. Thank you.
All right, thank you very much, Honorable Usman. He's talking about stratified advocacy approach. So Dr. Gafar has some questions. I think I will give him the window now to throw some of those questions at some of the panelists here. I think they're very critical. Thank you, Dr. Gafar. Please go ahead.
Okay, thank you very much, Dr. Francis. So let me start. When Professor Sabo made a presentation, I'm very sure most of us followed passionately. The money that we have for basic care provision fund will cover up to 1.2 million people. We've only enrolled 800, and it's only like less than 500 are actually accessing care. There are some donor projects that have put money in terms of buying health insurance from people. And the enrollment rate has been very, very good. And utilization has been very, very, very good. And when we put them side by side, Basic Care Provision Fund, there are a lot of things for us to learn because they achieve more. So Christian Aid is one of such organizations that has done that. So I want to find out from Obili, what do they do differently? What can we learn nationally from that approach? What was a very impressive one, they put money, they enroll people, utilization, skyrocketed. And so Dr. Obili, Chief Obili, what have you done?
Good afternoon, everybody. Thank you, Dr. Gafar. For us in Christian Aid, the journey on the universal health coverage has been a long one. We started in 2016 until late 2019, where we sat back and said, I think what we're doing is not really hitting the results that we want to achieve. So as an organization, we went back and we did a deep dive, looking at the work we've done so far. What have we achieved? What have we done right? What have we not done right? Which direction do we need to travel? So in early 2020, the result of that deep dive came out. And as a result of that, it bettered what we call the Universal Health Coverage, the Local Government Initiative, where we started like a bottom-top approach to our journey to actualizing universal health coverage. And from that, it bettered a new project that we call creating access and expanding the availability of people to health insurance. And we started that journey in Benue and also in Nasarawa. That journey has come 9 months, and out of it, we have seen enormous results coming out, especially from states like Nasarawa. I say this because the state has an enabling environment where the systems and structures are in place, and where the government at the apex is really running an open door policy and also willing to collaborate with external partners. So in that state, we decided to not only move into areas where others have worked so that we can really evaluate our work. So we sat down with the stakeholders in the state and we had a meeting that said, give us an LGA where you have not worked, and let us start something afresh there so that we can compare our results pre and post what we have done. So that was how we went into Kefi and started the work in Kefi. A lot of things gave rise because Christian Aid believe that not only should our intervention be inclusive, but it should also be people-centered. So the intervention had that at the heart of it and said, we're going to work closely with the people, not necessarily inventing new structures and systems, but to work with what is existing in the place. And with that gave birth what we call the Universal Health Coverage Local Government Committee, which was made up of the World Development Control, the primary healthcare providers, and a couple of influencers within the state. And with that, created a huge acceptance within the community. And with that, we were able to wriggle our way around the issues of trust. Because health insurance, one of the major challenges you have to deal with is the issue of trust. So with that, we're able to overcome trust. And we said, what we're here to do is to stimulate demand, because people don't ascribe to what they've not really tasted. And we said, for you to be able to know what it looks like, we'll be adopting 440 members of the community and paying for their 1-year premium. So that is what we did. And we went ahead and we adopted 440 persons from Kefi. We adopted 250 from Benue, and we are about adopting 100 from FCT. All these we are paying their premium for 1 year. And 5 months down the line, we decided to do a little bit of a comparative analysis, looking at what our data says when we're beginning and what it says after 5 months. And we found out that the issue of utilization went up in the 4 facilities where we were working. And we decided to know why. And we dug a little bit deeper. And we said, okay, what does it look like for those who walk in to access service? And we found out that the percentage of those who walk into access service was at 0.8 or thereabout. While those who were adopted were about 5.3, 5 upwards. And we found out that with the overtime, the activities that we have run, which was really moving along with the people of the community, ensuring that the ones who selected those who benefited, and also ensuring that the people who were benefiting from the adoption process was people from the community. And we found out that over time, the partners that we work with were following up on the beneficiaries, not those who were only accessing services, but those who were not also accessing services to find out where they have not accessed services. And with that, they were able to sort out some of the bottlenecks within the system. We also went a little bit ahead, not only creating demand, but also being an eagle eye on the service provision, ensuring that what we paid for is what people are receiving. And with that, those on the service provision side were put on their toes. And over time, we find out that our utilization shot up because we did not only choose those we wanted, but we chose those who really needed the services, who could not afford to go to the facility because they didn't have money to do that. And also, we found out that utilization was also as a result of the follow-up on the service delivery side. Because if you don't follow up, people will just fall off the tray and they will say it is a failed intervention. So over time, that showed us that yes, this works if you collaborate with the people to really choose those who will work on this and also ensure that your service is constantly being monitored and also issues around bottlenecks are settled over time. I think I'll use the mic here too.
Okay, thank you very much. Thank you very much, Obili. I think that was very clear in terms of utilization per person per year for the UAC project that you did because of a strong community component, which is around 4 or 5, which is the gold standard for universal coverage compared to those of that are not insured, almost 0.5 consultation per person per year. And like you've discussed with me earlier on, for those on basic care provision fund, it's around 2 consultation per person per year. Thank you very much. So, Dr. Lassan, you listen to Honorable Usman. Articulating agenda is very clear in terms of if we're engaging the political class in the next political dispensation. What do you want to tell them the priorities are? You've been doing a lot of great work in health security. What should the health security agenda look like that you want to present to the political class? Over.
Thank you very much. I do hope my voice is coming out very clearly. Yeah, so for partners, I think it is very, very important to work with stakeholders in country in identifying what the priorities are. And the good thing is we do have the National Action Plan on Health Security, for instance. We have the National Health Act. We have the health priorities. And I am a bit slanted towards the health security component of this meeting today because the Global Health Advocacy Incubator supports epidemic preparedness, supports advocacy, not only for increased awareness, but also for increased funding for epidemic preparedness in Nigeria, working at the national level and also working for now in 2 states, Kano State and Lagos states respectively. And so for instance, GHI has worked very closely with the civil society, particularly the Health Sector Reform Coalition, worked with legislators. We have quite a number of them who are, health and health security champions at the National Assembly, and that includes Dr. Ibrahim Oloregbe and Senator Utazi, Chukwuka Utazi, and also Dr. Tanko Sununu. They've been very great. So we've worked with all these stakeholders to help identify what the key priorities are at the national level, and then also worked with stakeholders in Kano State to identify what the priorities are. If you look at the National Action Plan for Health Security, for instance, out of the 19 key thematic areas, there are 4 that have been prioritized. Surveillance, you look at laboratory infrastructure, you look at the workforce capacity building, and then you also look at preparedness. And we all know that it is better to prepare because it costs you about 9 times more to respond than to prepare. And so to answer the question very in specific terms, these are the areas of prioritization. It is better to prepare than to respond. And this is very critical because we don't want a situation in which there'll be another round of epidemic and then we are caught napping and then we end up spending the colossal sums of money that have been spent in responding rather than preparing for the epidemics. Let me stop here for now. Thank you.
Okay, thank you very much. I think that's a very, very clear agenda. Thank you, Dr. Alassan. So let me come to Yusuf of Bill and Melinda Gates Foundation. Yusuf, thank you very much. You've been here since morning. You've seen the discourse and the direction of our conversation. It is very, very clear. We need to articulate the agenda. We need to engage not only stay in Abuja, go to state, regional level, engage other stakeholders. All this costs money. So, how does BMG want to support this initiative going forward?
Thank you. So, first and foremost, we need to put this in proper context. That in Nigeria, donor fund are a fraction of the total amount spent on the health sector. But the uniqueness of donor fund is that it's catalytic. It's catalytic in the sense that they are invested in the areas that have the highest impact. And so what do we look out for in doing that? So we work on 4 principles. 1, we look at what is being prioritized. Now, if you say, every governor you meet will say, health is top of my priority, and lately they've started saying PHC is a top priority for me. But we always want to see how states go beyond saying this is a priority. Is that person putting the right policy, the right structure on the ground to really show that PHC is a priority? And let's connect this with the conversation around universal healthcare coverage. We all know that primary healthcare is critical to achieving UHC. And so if a governor said he prioritized PHC, what are those things he's putting in place? Putting the right people in place to manage PHC, for example, who is the commissioner of health, who is the ED of the primary healthcare agency. Second, is the right reform being done in the system? I'm happy to see in Qatar, and I see Dr. Hassana also out there, people who have been working, talking about reforming PHC. Are we putting the right policy, the right strategy, the right interventions in place? What systems, what processes, and what tools and technology are we putting in place to ensure that we will have functional primary health care? Now, is this reform backed by financing? We still continue to talk about the 15% Abuja declaration. This is a declaration that has been done like 15 years ago. We should be thinking beyond that 15%. And will that 15% even be enough? And then are we really putting quality in our context? So if you look at it across these 4 themes, what donors have done across the board is to say, where will I be playing the most catalytic role? Or where will these little resources play the catalytic role? For the Basic Healthcare Provision Fund, if you look at the role of donors collectively, was to influence even the setup of the mechanism. We had to put in resources early in the day to ensure that the mechanism is in place, the right tools are developed for that. And happily today, government feel comfortable with that. They put in money there. Other donors like the European Union and co have also put a lot of money into that. So that's the way the donors group look at this whole PHC, UHC trajectory, but looking at where do we play the most critical impact. Thank you.
Okay, great. Thank you very much. I want to know whether Dr. Sam Agbo is online. If he's there, I'm asking the same question. Can somebody help me to check? Okay, it's not there. Okay, great. So thank you very much. So, but the organizers have asked me to please appeal to the panelists to remain seated for the next couple of minutes, where we just, how many minutes it take you to read the communicate? Just 5 minutes, and I've started counting. Okay.
Thank you very much. So the Universal Health Coverage Forum held the first Universal Health Coverage Summit today, 16th December 2021, at this venue. Some of the challenges of the healthcare system in Nigeria that have been identified include lack of trust due to inadequate transparency and accountability in government processes. Healthcare service delivery is still very low in Nigeria. We have less than 5% Nigerians still covered under any form of health insurance program. The heavy impact of the COVID-19 pandemic on the economy and the health sector cannot be overemphasized, and lack of appreciation of the benefits of democracy to health among Nigerians. Some policy options were identified, which include the following: use the political campaign season to put health in the political front burner by developing deliberate manifestos towards attainment of UHC Nigeria. Explicit benefit packages and coverage rates per investment in health to guarantee good return on investment. There is need to promote UHC through expansion of healthcare insurance coverage by developing a holistic healthcare insurance plan and make health insurance mandatory for everyone. There is also need to leverage on digital technology that will improve data gathering, analysis, and inform decision for health towards attainment of UHC Nigeria. Important roles of the political class we have gathered here today include that the subnational government need to improve investment in health sector. For example, ring-fencing the policy of earmarking and eventual release of the 1% consolidated revenue fund for health. The national and state assemblies need to use their appropriation power to ensure minimum of 15% allocation to health sector is in the budget, and of course, their oversight power to ensure monies appropriated are utilized for the purposes for which they are allocated. We have also been able to identify roles of civil society that include citizens' awareness on the importance of investment in health beyond constructions of infrastructure generally. And there is need for effective engagements at the community level, leveraging sociocultural norms and languages to gain traction on health insurance enrollment and involving them in discussions on health policy issues. We were able to identify, through the contribution of the traditional leaders, ably represented by the Emir of Shunga, His Royal Highness, Dr. Haliru Yaya, that there is need for the traditional rulers to continue to hold the politicians accountable to their campaign manifestos and make recommendations to government in power as it pertains to the health needs of their people, because they are closer to their people. Commitments that were also obtained from other political classes. The Nigerian Governors Forum committed to recommendations contained in this communique, and they are going to submit to the governors for deliberate actions. The representatives of the state governors and other political leaders at this summit, they have pledged to relate the summit communique with their respective executive governors and the state executive councils to ensure implementation of pro-UHC policies in their states. The donors have promised that they will continue to give their technical support at the national and subnational levels in implementing health policies towards attainment of UHC. The Chatham House committed to providing technical assistance to Nigeria to launch and sustain UHC, share experiences with successful UHC models, political economy of UHC, and generate political commitment for UHC, among others. The media are going to use their platform to engage political actors on the inclusion of health reforms in their party manifestos. And they are going to serve as advocates and watchdogs to the political class in holding them accountable to their manifestos. I want everybody to know that this is an abridged communique There is a robust communique, but because of our time, we needed to ensure that the most critical and pertinent ones were read out. Thank you and have a good evening.
Thank you very much. You deserve something better. So I've been mandated to release the panelists now. So thank you very much. Dr. Francis, you want to thank your panelists and take picture with them. So while we are doing that, I will invite, so let's have a
Thank you very much.
Dr. Ahmad, you are saying something?
Maybe I think I'll get my comments on the communique. I think I'll get back.
Okay, do you have a comment, quick one, sir? Not yet? Okay, so let's the panelists have picture. While we're doing that, so a lot of important things came out from the communique, but in terms of next steps, we want Juliana to tell us, as a forum, what should we do? 1, 2, 3 things we will do going. Juliana Aribu Abude, who is the executive director of LISA. She used to be my girlfriend. No. Not anymore any longer. So Juliana, over to you. Why are your videos should prepare to give us the votes of thanks?
Thank you, Dr. Gafar. Good late afternoon, everyone. I would like to thank you before the vote of thanks happens for participating, for the rich discussions that we've had here today. And it's really commendable that everyone has remained and sat through these very important discussions that we've had here today. I think our next steps are cut out and very clear. We've had several recommendations and outputs. The communique, a brief has been presented. So we've agreed on 3 very broad next steps. The first, and I'm sure you will agree with me, is putting everything we've heard here today, all the recommendations, into a roadmap for the UHC forum to subsequently implement and track. So we intend to follow up with every stakeholder we've met here that has presented and recommended next steps to us here today, and also engage the community structures, traditional and religious leaders to provide some direction on this, and of course, cascade the discussions to the communities. You agree with me that that's where most of the votes come from, and it's extremely important that we get it right. We also will be developing an engagement strategy to ensure that we do this correctly and that we don't leave any stakeholder out of the discussions. And of course, it will also be important to have a sustainable framework going forward. Because once the elections are done and we have the new political dispensation in 2023, then what will be the UHC forum? What will it be called then? UHC 2027, I can tell you now, because we will not be relenting on this duty as Nigerians. And from all the discussions around manifestos, of course, it's become very clear that we will need to develop a draft template or a manifesto template inclusive of all what we want to see for the health sector, and of course, human capital development, because health is at the center and every other thing revolves around it, that we will use to engage political parties going forward. And I dare say that as soon as we have a template, we'll circulate to everyone here for your input. So again, pardon me, we get it right. So thank you very much. My name remains Juliana Abude Aribo. Good evening.
So thank you very much, Juliana, for that next steps. So I want to remind us, please, to remind us that we are here to take our lunch. So when we finish, please, let's branch and take our lunch. So on this note, I would like to invite Miss. I was tempted to say Dr. Mrs. Mojo. So Chief Mrs. Mojima Kajuola, MFR, right? To give us the votes of thanks.
Yeah. Well, we have Royal Father here, commissioners, representatives of executive governors here. 24 hours ago, if I was told I could stand and in front of you and be able to do this, I would say no. But the medical world and science has made it possible that some medications can keep you standing. So we need to embrace and ensure that it goes on. I'm holding on to this young lady because I needed to do this. This young girl deserves a very loud round of applause. For me, she represents the hope for Nigeria tomorrow. Ayomide has been in the forefront of this, getting memos to everyone, ensuring that we get our notification for meetings, ensuring that even taking the minutes of the meetings, before you know it, in another 30 to 45 minutes, Ayomide has hit your phone with the tangibles or with the main issues and with the discussion and conversation going forward. So I want to celebrate her. Please, can you celebrate Ayomide with me? Everything here is made in Nigeria for Nigerians. So Ayomide, give us vote of thanks.
Thank you very much, Ma. Thank you, Ma. Good afternoon, everyone. On behalf of the UHC Forum, I would like to extend our profound gratitude and appreciation to everyone that is present here today. Our executive governors, legislators, commissioners, Minister of Health, who are present and ably represented today. We appreciate your political will and commitment to advancing UHC in Nigeria, which is reflected in your past and current efforts, and also in you being here today. Our profound gratitude also goes to our distinguished speakers and panelists, and also all the participants here today, all the attendees. We really appreciate you for being here and for the brilliant discussions and contributions that you have given to this summit today. We really, really appreciate you. I would like to also appreciate every member of the UHC Forum, UHC 2023 Forum, and the partners who brought this summit to forth today. We really appreciate your efforts, your contributions, the Nigeria Governors Forum, the Chatham House, every single partner who has contributed to bringing this summit to an actuality today. We really appreciate you. Then to our donors who have remained a strong source of support to the Nigeria health system, and have also committed to continue to provide this support to the health system in Nigeria at the national and subnational level in this summit today. We appreciate you, and we look forward to the support which you have committed to. And to the CSOs and media who are the voice of the people, amplifying the voice of the people, and also holding all the relevant stakeholders, including the political actors, accountable to ensuring that universal health coverage becomes a reality in Nigeria. We say thank you for being here today, and we look forward to your further efforts in holding every relevant stakeholder accountable to every commitment they have made at any point in time, including here in this summit today. Thank you all for being here today, and we look forward to the collaborative efforts of everyone here towards making sure that health is a key political priority in the upcoming 2023 elections, and like Madam Juliana said, even beyond that. Thank you very much, and have a good evening, everyone.
Thank you very much. I think the next section and the next assignment here is lunch. So because we have done so well, we deserve lunch, and let's go and have our lunch. And by the power conferred of me, I would like to declare this summit closed. Thank you very much.
The political declaration in front of us is the most comprehensive agreement ever reached on global health, a vision for universal health coverage by 2030.
Sorry, members of our US from here, please, if we need any for group photograph, please. Members of USC 2023 from here in the room, let's come up for group photograph, please.